Please.
Thank you so much, respected seniors, my dear friends, colleagues, everyone for this half-day CME on specifically on benign esophageal disorders. And we have chosen this Saturday of the month, and we expect a lot more consultants and faculty to join us as we go along the way. So this is a purely academic session, but in the middle of the session, I've kept a little life beyond surgery sessions, small talk on spirituality and the surgeon, which all of us need, and money matters, which not all of us are very conversant with. And at the end of the program, we'll have the best state chapter that Delhi has won for the 7th consecutive time. Dr. Sarangi sir will be coming as the ex-president of the Delhi state chapter, who will be taking us through the journey of how Delhi won the best state chapter. So without taking much time, I'd request Tanushri to please invite the panelists and the moderator for the first session.
For the first session, I would like to invite on stage our moderator, Dr. Prabal Roy. He is the Director of the Department of General, Minimally Invasive and Bariatric Surgery at Accord Super Speciality Hospital, Faridabad. Okay, so for this session, that is the right surgical candidate in GERD, I would like to invite our panelist on stage, Dr. Anil Arora. Sir is the chairman of the Institute of Liver, Gastroenterology and Pancreatico-Biliary Sciences at Sir Gangaram Institute of Postgraduate Medical Education and Research and Sir Gangaram Hospital, New Delhi. So lovely to have you here. Thank you, sir. Next, I would like to invite Dr. Rajendra Prasad on the stage. Sir is the professor and senior consultant at Department of Surgery at AIIMS, New Delhi. Sir, thank you so much for coming. Next, I would like to call the most punctual sir who has come here, Dr. Sabyasachi Bal. Sir is the director at the Department of Thoracic Surgery and the Thoracic Surgical Oncology at Sir Gangaram Hospital, New Delhi. Thank you so much, sir. And lastly, I would like to call Dr. Sumit Shah on the stage. Sir is the Director and Head, Bariatric and Metabolic Surgery and Senior Consultant at PSRI Hospital in the Department of Laparoscopic Surgery. Thank you so much, sir, for coming. Prabal, sir, over to you now.
Good evening, everybody. First of all, thank you so much for inviting me over Delhi State Chapter. I belong to the Haryana State Chapter. So, we have a very interesting talk here, and a very interesting and a very illuminatory group of panelists on a topic that is pretty much medical. Thank you. So the diagnosis of GERD, is it still an enigma? that is my question to the eminent panel. And some of the panelists I know from before, and sir, we haven't met, but I'm sure this is a wonderful meeting today. So it's lovely. I have had the opportunity to communicate with my panelists before, so that, surgeons be online to what the physician thinks. It's not a surgeon versus physician thing at all. So briefly, historically, see, when I'm the first speaker, I have got a lot of opportunity to transgress into everybody's field and space. So later speakers, please bear with me. Don't take it to heart. We'll try to maintain our time. Shakespeare and Richard III, the third said, this is a malady of kings and queens. I think they ate more, became more fat, and they had a lax LES. So that's how. Gallen also spoke something about the food pipe having inflammation. Allison in 1948 first time described hiatus hernia as one of the causes of symptoms of GERD. Nissen in 1956 did the first, reported the first fundoplication. And here there is a very, very small anecdote I want to bring to everybody, that there is a very interesting relationship between Nissen and Einstein. Einstein operated on, Nissen operated on Einstein for his abdominal aortic aneurysm. When it had ruptured, he just covered it with kitchen foil, and he managed to live for 5 years after that with the same rupture. So then gradually a lot of new things happened over the next few decades. A very interesting term called TLESR, transient lower esophageal sphincter relaxation, was recognized in the 80s, and it was kind of understood. Then the PPIs came in 1989, which was actually an explosion. After that, the surgical consideration actually started becoming less and less. But then, there came a savior. Dalmine in 1991 did the first laparoscopic Nissens. Again, there are a few angels in surgery who allowed general surgeons to thrive for now 91 to 2024, so that is close to 35 years. I think laparoscopy has done a lot good to surgeons as well as to the patients. So we still have some existence left. So the first part, as we start, I thought enigma is what the topic is about. So is it really an enigma? Is it that mysterious? Can we put it to vote? Is the diagnosis of GERD really an enigma? How many people say yes in the audience? Audience poll first, then it's the turn. Nobody feels it is an enigma. No, it's not an enigma, means you know everything about it. Few, 1, 2, 3, 4, 5, maybe. Maybe is a little more. Maybe is a little more. And in our esteemed panel, yes, it is an enigma. 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 Oh, you're going to get voted out. they are all in favor. So, whenever there is lack of clarity as to where we are likely to reach and how to reach that path, there are multiple ways to reach it. It's just like religion, it is whether it is Allah or Bhagwan or whosoever we want to follow. There are different paths because none of them are perfect. None of them actually make us reach where we want to reach. So there is a huge armamentarium of investigations that have been thought, including a very good history. I think probably one of the most important things is history. So now my first part of the question is, if there is a person who has got reflux symptoms, do we always go for an investigation first? So everybody, all of us in our clinics get patients with reflux symptoms. So do we start with investigations always? Sir, I can start with you, Dr. Prasad.
So as a surgeon, we normally get patients who have already been treated or put on PPIs or investigated. It's not very common for us to see a patient, but supposing it's a hypothetical situation for us that a patient comes to you with symptoms of reflux, they are typical symptoms. If the symptoms are typical, which means there is heartburn, regurgitation or chest pain, in that scenario, yes, one may start with a trial of PPIs. because patient does need some symptom relief. But in general, to make a diagnosis of GERD, I would say that particularly actionable GERD, where you want to do some intervention, you would definitely want to put them through a battery of investigations.
So I made a mistake. I spoke to the top referral hospital doctor first. So nobody is going to come to you, sir, to asking for a diagnosis. They'll all come with a diagnosis and would like. Dr. Arora, sir.
Yeah, you see, we also work in a tertiary referral center hospital, where if the patient comes to you for the first time, you tell him that, oh, let's go by the typical classical algorithm that if you have classical heartburn, try 4 weeks of PPI. If it doesn't help you, and especially if you do not have any alarm symptom, then we can go and investigate. But at a tertiary referral center in gastroenterology at Gangaram Hospital, most of these would have already been through a number of PPI courses as well as investigations. Now they have come to you for a second opinion. Whether is it related, all symptoms are related to the reflux, and can something be done in addition to PPI, or can they get rid of PPI? That is the time when you have to establish a diagnosis rather than continuing empirically. If they were to continue empirically, they'll not come for a second opinion.
So I have one point to make here. See, my issue here is that how many people in the audience say have tried or asked their patients not to undergo an investigation prior to a 4 or 6 week PPI therapy? How many people? No investigation without PPI therapy. 1, 2, 3, 4, 5, say close to about 30-35% people here. So in India, we are under a lot of pressure from the patient to do something more for him. So endoscopy is more or less like a rectal examination that we give in our OPDs. That's how it has moved on. So should we consider that to be a routine practice, or should we modify this practice to the content that yes, you've come to me, maybe you've done your therapy for 2 weeks, or you've done it more irregularly, you've not done your lifestyle measures at all, you try it out for a period of time. If it works, good. If it doesn't, then come back again. Is that a policy that we should think about, or we go as we are going?
Yeah, I think it all depends on with what symptom is the patient presenting to you.
Non-critical.
I'll tell you, the classical example is misdiagnosis of achalasia with reflux. In both the condition, you have regurgitation, you have food coming from your mouth, you have vomiting. And for ages and for donkey decades, patients are not diagnosed to have achalasia where they are being treated for reflux. I think an astute clinician's duty is to listen to the symptoms and to diagnose it correctly, especially if the patient has come to you at a secondary or tertiary level hospital, rather than again putting them back on a mill of PPIs. That is where you have to step in. And if you see achalasia cardia, which by default starts in early childhood, average age of diagnosis is 30 to 40 years. Everybody treats them as reflux because you have vomiting, you have pain, you have regurgitation. But if you just spend one more minute, ask them, does he have any problem in swallowing the food? Now, swallowing is something, dysphagia, which will never occur in a functional manner. Anything else in the body can be functional except dysphagia. It has to be organic. So, my assessment will be re-evaluation of the symptom, look at the totality of the duration of the symptom and the way the disease has progressed. If there are no alarm symptoms, and if the patient says, oh, after a heavy meal, if he is not able to rest, he has symptom, there's no harm in giving him another trial. But if the patient is an elderly gentleman, recent onset weight loss, recent onset new symptoms, I'll also like to investigate him for other things, including coronary syndrome, for all the things which the patient will be presenting to you. I think a good clinical assessment when the patient has come to you gives a good credence to your speciality as a clinician.
Perfect. So we've come to some amount of conclusion on this part.
So may I just say one thing?
Sure.
So you don't start a patient on PPA for the purpose of making a diagnosis of GERD. It is for a transient symptom relief while you are, assessing whether he responds or whether you are going to do any further evaluation. Because there's so many patients who will come to you with a bit of a heartburn, bit of this and bit of that. And I think symptoms are very unreliable as far as making a diagnosis of GERD. So if the purpose or objective is to make a diagnosis of GRD, then trial PPI is, I think, not a good idea. It is just to kind of give a symptomatic relief to patient or give a trial while, because you are not going to be able to do everything on the day when somebody comes to you. So it's a, I guess, a common practice which is followed everywhere, and they will.
Dr. Sumit, you'd like to add something to this?
I think when a patient comes, he's got a mixture of symptoms. Some symptoms of reflux, some sort of dyspepsia, some stress-related symptoms which can, which could be, some symptoms of IBS. So he's got a mixture of symptoms. If the patient has got clear-cut reflux symptoms, we are glad because now we know what we are treating. At least, he's presenting with classical symptoms. But in a general OPD, it is unlikely that the patient will present with classical symptoms. You don't know which symptom to ascribe to what. And usually it so happens that these patients are not very keen to go in for an endoscopy at the first step. Maybe if they go to gastroenterologist, they already have a mindset that they will get an endoscopy done. But if they are not going to a gastroenterologist, but to a general physician or to a surgeon, we actually have to convince them if we want to get an endoscopy done, which is not easy. I know gastroenterologists having GERD who are taking PPIs for 15 years and never got an endoscopy done. So, so that also happens. That is my opinion. So it's a mixture of symptoms and you have to filter out what is causing what in this patient, not at the same time functional, very important.
Exactly. So now we heard a very good example here that even gastroenterologists take some time before they undergo an endoscopy on their own. But then I have a question here, which is for Dr. Arora. I tend to agree and disagree. Disagree because the text says something else, but I agree with him is because I believe one of the biggest challenges in endoscopy is that a person has already been on PPI for a significant period of time. Until and unless there is a structural defect, he will not be able to make out anything on the endoscopy because the endoscopy will come out clean. So there is probably a role. A panel is also about the moderator's confusion. So, sir, if you could clarify this one part.
Yeah, what is the question?
My question here is that if we give a long duration, 6-8 weeks PPI therapy and then prefer an endoscopy in that patient, the mucosal lesions would have healed in case there is no structural issue. In case there is no large hiatus hernia or a hiatus hernia at all, you may not be able to pick up anything at all.
See, if you look at the physiology of the reflux, by default it is a physiological phenomena. It will occur in all individuals for a particular duration of the time during day and night. So we are not treating reflux. What we are treating is pathological reflux, and for which the patient has come to you. If the patient has come to you, as I said again, if the patient knows that these are the aggravating factors, if there are no alarm symptoms, even all guidelines would tell you a 4 weeks trial doesn't change. Especially if you are not elderly, you are not lost weight, there is no anemia, no dysphagia, there is no harm. Now a delay, even if you do endoscopy at that time, we know that 50 to 70% of the patients during initial evaluation on endoscopy may have no morphological evidence of overt mucosal injury, thereby meaning they have something called non-erosive reflux esophagitis, which is commoner than erosive esophagitis. So our assessment as a gastroenterologist is not to look for erosion. If there are erosion, you have a telltale classical evidence of which is banging on your face, this is reflux. But then when you are doing the endoscopy, you are also looking at G junction, you are looking how patulous it is, you are looking at the columnar squamous epithelium junction and diaphragmatic end. And there is an excellent way of diagnosing hiatus hernia during endoscopy, which has very good positive and negative predictive value. And also when you retroflex the scope, you look at how patulous G junction is. So if the patient has had classical symptoms of reflux, and if you see a patulous wall with small or moderate size hiatus hernia, so that leaves no doubt to symptom correlation. So that is, it's not that you're looking only for reflux or you're looking only for erosions. You're looking for patuosity of the G junction, you're looking at the hiatus hernia, the degree and the location of the hiatus hernia. That is an additional information.
So, again, pulling you a little bit more into the discussion.
Yeah.
Unfortunately, it is a very diagnostic topic, and I think you're going to get the largest number of pointers here. What are the dilemmas that you face when you have a patient who's typically having all the symptoms, but you find actually nothing on endoscopy.
Yes. In fact, that is in fact commoner situation
Yes.
than those who have a hiatus hernia. The dictum is majority of the patient with reflux will not have hiatus hernia. Majority of those who come to us with reflux do not have hiatus hernia, but once you have hiatus hernia, majority will have reflux. That is a dictum we have to remember. So we are not surprised. This is what we are used to seeing it. Now is the question comes, as Dr. Saab said, so part of the symptomatology may be functional, may be related to the stress. Then you move on to the second battery of investigation. Then you have to threadbare discuss all symptoms. Is it more of reflux? Is it more during night or day? Is it acidic? Is it associated with regurgitation or vomiting? So that will contribute to your second line of investigation, which can go anywhere from esophageal manometry to 24 hours ambulatory pH monitoring and even impedance monitoring.
We'll touch that very shortly. So, Dr. Sabyasachi, now, where do you feel that endoscopy is sufficient? It is enough to indicate surgery. We've reached here, this spot, our first milestone, endoscopy done. Now, where do you feel that surgery would be indicated?
So, I mean, has this patient received adequate medical treatment or no?
Patient has received medical treatment, patient has undergone
not
an endoscopy.
responding.
And at endoscopy, what are the findings that tell you that you do not want any further investigation, or there is no such situation, you would always demand more investigations before you go in for surgery?
I think considering the fact that Dr. Anil Arora just said that a certain proportion of patients will have motility disorders as well, I think it would be probably be unwise to operate on the basis of an OGD alone. And I think one should rule out that there is no motility disturbance in the esophagus before you went for surgery, whether it's minimally invasive, whether it's endoscopic surgery, or whether it's laparoscopic surgery as you do. I think one should be aware that we're not dealing with two pathologies rather than one.
So,
I think for very long, most of the surgeons used to do on a basis of symptoms and a endoscopy itself, right? If the patient had grade 1 esophagitis, small or moderate hiatus hernia, this and the symptoms of reflux, this was good enough for most surgeons to do a fundoplication for very long, right? That is because the facilities for doing more intensive pH studies and manometry were not easily available. And these experts, those who are have expertise at these, were also not there. So, because that is why, for a very long time, doing pH and manometry was not the kind of norm for most of the laparoscopic surgeons doing fundoplication. I think things have changed in the recent past, with all big hospitals now having esophageal labs and expertise in doing this. So, I mean, 10 years back, I never used to hear so much about pH and manometry.
no, not at all. We didn't have a
That may also be the reason why, if you see older series of surgical satisfaction,
yes.
it was much less than what it is today.
So, today we have studies that also indicate whether PPI is going to be effective in a particular situation or not based upon manometric and pH studies. Sir, you wanted to put?
I would like to just, my answer to this would be no. Because we have seen patients, I have seen patients operated in good hospitals purely based on endoscopy. And then they come back and then you don't know whether they ever had GRD. Now you must understand, first and foremost, we need to define what is GRD. What is the modern definition, what has Leon 2 now proposed?
Yeah.
It has proposed that there has to be an evidence of reflux based on endoscopy and or pH studies in presence of
Symptoms.
troublesome,
Symptoms, yeah.
but they have added a word, compatible symptoms.
Compatible symptoms, yes.
See, troublesome symptoms, right now I have a patient who has had a fundoplication done, no response. Patient comes to your OPD, within 5 minutes you see she is just belching away. All the time she is belching, burping and belching.
Sir, mic has to be closer.
Burping and belching. No, obviously belching, supragastric belch, rumination, These are 3 or 4 things which do not respond to surgery. And many patients get referred for surgery. I end up turning more patients away than I accept for surgery because their symptoms have nothing to do with the actual GRD. And these symptoms are not going to respond to surgery. And she's belching away now. Now she wants, and somebody has now convinced her that they will do another surgery and try to. No. So this is what I'm trying to tell you that.
So would you reverse? Would you reverse the surgery?
No, because
belching
doing
could be-
anything in this
belching-
situation
The belching could be a part of a bad surgery also.
of
A gas bloat could be a
gas
part of
bloat.
bad surgery
gas
also.
bloated patient is not able to belch.
Yeah.
Gas bloated patient is not able to belch. Belching, of course, what we would do is evaluate her anatomically if there is a abnormality, if
Yes.
there is slip trap. If none of that is there, any further surgery is not going to help.
No, I transgressed. I will go back to what we were talking about. So, this is something that I added after I discussed and shared my slides with you. This is Dr. Arora's very keen interest. Anyone in the panel still doing barium swallows in patients of symptomatic reflux who have undergone an endoscopy prior to?
Before surgery, we do barium in all.
In all.
As a rule.
Every single patient.
Every single patient.
You too? Not routinely. So in the audience, what is the call? How many of, let us poll, Delhi's polling in 5 days. Come on, everybody should poll. Anna? 5 days, 4 days, 4 days. So, how many people carry out routine barium swallows prior to surgery? It is a minority. Only for revision. So, the majority of the panel believes that we should do a barium prior. And there is a very significant evidence to it.
So actually, I just like to, I think most of us will do a barium not because we want to find out whether it's a hiatus hernia or not, or whether there is reflux or not. Because I think the criteria of detecting hiatus hernia on the barium, right, are very tenuous. Many things can't be recognized. It's not as clear as you've shown, right? And I think most of us will do a barium because they want to rule out the possibility of other events or other issues that may be involved in this patient. At least I would. I mean, I don't think I would do just to find out it's a hiatus hernia.
So what would be your battery? First is symptomatology, second is...
So I'd
but
follow the
yes,
Leon convention completely, sir, that the symptoms are pure, reflux and regurgitation attributable to GERD, and which are supported by endoscopic, physiological or manometric studies.
So this is the sequence. It has got significant roles, so there are a lot of people who did not vote for it. This is something that needs to be done. Very simply said, Dr. Arora has a little counterpoint to that also, some additional point. Yeah. I won't say a counterpoint. Dr. Arora spoke to me in the morning today and he said something very interesting. Sir,
Yeah,
very
I tell
briefly,
you,
very
see,
briefly.
if you see the younger lot of gastroenterologists, they are so used to reporting hiatus hernia, which suits the surgeon, younger surgeons also. You have any reflux, endoscopy says hiatus hernia, then why think twice about it? And when we repeat the same endoscopy in tertiary center, 8 of the 10 times you have no hernia. The connotation is, I am sure you will agree with that. And connotation is, if you have a hiatus hernia, then we, in addition to giving PPIs as endoscopies, I'll be presenting my talk on that, we have an excellent endotherapy of reflux esophagitis. So if you have a big hiatus hernia, it is all surgeon's baby. I just totally withdraw out of it. We hand it over to our surgeons.
So therefore,
There is an additional advantage of look.
so for the group sitting over here, we have to...
ICARS guidelines 2019. ICARS guidelines 2019, which was actually for the purpose of selecting out patients for surgery. They recommend barium. And as a surgeon, I would need a roadmap. It's always better.
Perfect.
We have seen enough number of times somebody reports large hiatus hernia and then you do a barium, there's nothing. You cannot have a patulous hiatus, you may not see a hiatus hernia. Right? But
Agreed.
large hiatus hernia reported, you do a barium, there's nothing there. You have to kind of think about it
So,
carefully.
One question to the moderator. What is the gold standard for hiatus hernia if barium is not reliable?
we're going forward on that.
Is that the pH is the gold standard?
Not pH alone.
Can we go to the last slide?
Not pH alone.
I think motility studies may be.
Everything together. I'm coming there.
So what is gold standard? One test.
So it has to be. See, manometry is a short duration test.
But manometry came only recently into being.
So barium, of course. Dr. Bal just said that we can rule out other
That is
pathologies of barium.
precisely the reason we have been always insisting
Agreed.
on barium before subjecting the patient to surgery. See, if you are giving empirical therapy, it is justified.
So it's a very simple test to do. Only thing is that your technician has to, the radiology technician has to be made more sensitive. The barium swallow report films that we see today are not appropriately exposed. So therefore, so many times we don't get it, as Dr. Bal just said some time back. So we'll have to rush a little. Our time is also getting tight. Does the pH study make us wiser? Always or sometimes?
Always.
Always, yes.
Especially if you are contemplating endotherapy or surgical.
Surgical therapy. So pH study is extremely important. We cannot miss out on it. And there are many parts to it. Sir.
So there may be situations, exceptions to this are patient is a volume refluxer, predominant regurgitation, there is a large hiatus hernia. In these situations, your pH probe may not actually go. We have seen that. It may not be accurately placed and you may actually get a fallacious. So volume refluxer, a large hiatus hernia, clear evidence of esophagitis, you may not necessarily do a pH study.
So I came to the...
You don't need a pH. That is what I'm thinking.
So,
always, when we say always,
so then I come to modify this statement. This is where I asked everybody that is there and I subjected myself to total submission of the panel that in my practice, I agree, in case there is a patient who's got a large hiatus hernia, patulous hiatus, and has clear-cut symptoms that match, OGD is sufficient to go ahead. But then the panel at that point said,
OGD is not sufficient if I want to intervene, because then your symptom correlation has to be absolute.
absolute. So I gave that space.
Just a patulous hiatus hernia on endoscopy and symptoms, no. We will need further evidence. If they have a level C or D or even nowadays they say B also, LA, B, C, D esophagitis with typical symptoms, that is a different story.
So endoscopy will define that ulcer.
Yes, but
the mucosal lesions. So therefore, there is a role of surgery in selected group of patients, with OGD alone.
Yeah, large hiatus hernia, Barrett's.
So exactly. So that's.
But even then, before surgery, I would still do an anatomical evaluation
with a
barium.
With a barium. Okay. So there are a lot of recent modifications in pH monitoring, and they've got a lot of rationales. Does it really make a difference? You've got a lot of studies.
Yeah, see, this is specially needed in a subgroup of the patient who are non-responder to PPIs, who do not have a large hiatus hernia. Still they are symptomatic. This is a classical setting. As Dr. Rajendra very elegantly said, you are looking for non-acidic reflux, you are looking for volume. After all, PPI are only going to neutralize the acidity. They are not going to trample your volume loads. So this is a subgroup of the patient, classical symptoms, no hiatus hernia, no response to PPI. So you are looking for a non-acidic reflux and a volume reflux, which will be given by this new methodology, which incorporates pH monitoring as well as impedance monitoring. Difference is that the impedance monitoring also looks at the volume, and which may not be acidic. It may be something like bile or alkaline fluid which is coming up. The liquid and the air gives a different impedance. So any air reflux or a volume non-acidic reflux will be easily picked up. That will add up to our mentorium of either doing endotherapy or surgical intervention.
So there are two situations. One is called a gas reflux and second is a non-acidic reflux. They both can also be picked up, especially in patients on long-term acid suppression. They may have just these two. So therefore, there is a very good role for these advanced techniques.
Also, I think impedance you can do even while the patient is taking PPI. If correct me if I'm saying wrong, but in the regular 24-hour pH monitoring, you have to stop the PPI for at least 7 days. and you have to stop the H2 blockers for at least 48 hours and the antacids for at least 24 hours. So that is another advantage.
So I would say there are, if you have a doubt of supragastric belch, gastric belch or rumination, that is where your impedance will help. It also helps you to see the number of reflux episodes, as Dr. Arora said, that non-erosive, you may have reflux, it's neutralized by acid or something or other things. So the number of reflux episodes also. So it definitely has a selected role in selected situations.
So how many
Gives you
MNBI
information, it also gives you information where the reflux is.
Yeah.
If the reflux is going right up to the, say, upper esophageal sphincter, that means a huge volume reflux. This patient will never be benefited by PPIs. And regarding the on and off therapy PI, there are different parameters. Our dilemma is patient is so symptomatic, if you tell him PPIs have to be stopped at least for 7 days. Because Dr. Sir, मैं तो एक दिन नहीं रह सकता. So how, then he'll leave you. So rather than making him leave us, it is better to continue, and we have different parameters of assessment.
Recommended for diagnosing refractory GRD, you should do it on PPI.
Yes.
That is only way to show that you still have reflux in spite of suppressing acid, but not suppressing volume, which is the cause of
So
this.
the next question to you again is, how many MNBIs do you think are generated on an average in a very high volume center also in a month?
You see, this is a subgroup of the patient.
Yes, very small subgroup, that's why I'm asking.
Yeah, this is a very small subgroup of the patient in which you hardly ever see these patients like this. Most of our patients who have reflux, they still have acidity which is giving him the trouble rather than the volume. And most of them with volume will have a hiatus hernia.
Yeah.
That is the issue.
So it's useful in a set of patients, in very selective set of patients, wherein we need to go for more advanced kind of situations. So
I wanted to ask Dr. Prabal, I read about this Bravo capsule which they put in the inside, and it can record without the catheter inside for longer period of time.
Up to
So
72
please
hours.
can you, yeah, I didn't know about that. Can you
Yeah,
tell
this
us?
is a company called Cooper. So they have given this capsule called Bravo capsule, which can stay in the esophagus. You have to clip it in at about 5 centimeter above G junction. It records the pH and now even impedance for a period of 48 hours.
40 hours.
Conventional test like pH monitoring, which we do on routine basis, they do record it for 24 hours. This has the ability to record it for 48 hours. So you have a better visualization of variability of the reflection.
Sir, one of the
Any
articles,
idea cost, sir, how
It's
much?
still not available in India.
It's not
in one of
available
the
now.
articles it mentions 72 hours also.
Yes.
So wireless
72.
pH monitoring, wireless pH monitoring.
Bravo.
Now they say that wireless pH monitoring for 96 hours will actually give you the best outcome.
Better outcomes.
But it's not, here it's not available, so I think we don't, this.
So what is the cutoff for normal for this, the number of reflux episodes?
In fact, we have excellent data primarily from the US as well as from Europe. We do not have very good data of volunteers from India. Now it depends on whether you're talking about nocturnal reflux or daytime reflux and total number of reflexes or the duration of the
So I'm
reflexes.
talking about the total number if you're monitoring the patient on.
Yes. So what we calculate a score called Demister score. That is something which is a composite of total duration of the reflux, number of the reflux, and nocturnal versus awakened reflux. Any Demister index of more than 15, that means it is pathologically significant. So this is a composite index.
So acid exposure time more than 6% is definite, less than 4% is no, between 4 and 6 is a gray zone where you might want to do other things. And the number of reflux episodes more than 80 is definite, less than 40 is not, and between the two is a gray zone.
So there are some, now I'll have to bring something for the surgeons also. So I thought I'll come to certain clinical scenarios. You have a patient who has had good response to PPI but relapsed after stopping therapy. OGD shows no structural issue. pH study shows high acid exposure time. And patient continues to be symptomatic. What would you do?
I will offer him a anti-reflux surgery.
There is no structural issue. Now this is where the challenge lies.
Yeah, but anti-reflux surgery works for.
Can we do something less?
Yeah, I mean we can do. I mean there are newer forms of therapy that we can do,
Yeah.
including putting that Lynx band and all that. But I'm not in favor of putting any kind of foreign body around the GE junction because we have had terrible experiences.
So from the surgical standpoint, I mean,
Yes, sir.
of course, I mean, this patient will benefit from intervention. Now, what intervention you do
Exactly.
is another thing.
That's
As a
what I was
surgeon,
asking.
we can do either a magnetic links,
Links
this
band.
thing, which has shown decent results in patients who do not have a large hiatus hernia or a small hiatus hernia. Although we don't have it here, and I don't think I have used it. But yes, intervention is likely to help him. And surgical intervention is either in the form of magnetic band or fundoplication.
There are some there are a few recommendations that have come in now for these kind of patients.
You see, I think I'm happy that my teacher, Dr. Bal, is sitting with me. So this concept of augmenting the LES is age-old. See, people were injecting submucosal pellets and blebs and magnets and whatnot. Now, same thing has been propagated outside the LES, from outside, by this person called Hinoi. He's the guy who invented the third space endoscopy. So they have been causing the burns in the submucosal region at LES, and as they constrict, it causes narrowing at the LES. This is all done endoscopically. This procedure is called ARMA, anti-reflux mucosal ablation. So that is an alternative. That is precisely the reason you need to know whether there is a reflux, whether there is a hernia, and how big the hernia is. So only a small hernia can be handled. Bigger hernia is your big.
So as I said, there is no hernia. There is no structural defect.
Yes.
So again, there is another situation wherein there is a poor response to PPI. This person has never improved on PPI at all. There are so many we find who have no structural defect. So would we like to do something on these patients?
You see, poor response to PPI, you will have to interpret why is the response poor. In fact, if you look at the neutralization capacity of the acid, it is of the currently available PCABs and PPI, it is almost 100%.
Yeah.
The fact that patient is not responding, so is it volume reflux or
Yes.
it is non-acidic reflux?
Okay.
Now, volume reflux cannot be handled by endoscopists. You have to do either some suturing endoscopically or something.
So, and also I read somewhere that, different PPIs have different kinds of effect or the percentage of success. For example, I think certain PPIs have more effect and so on. I think there is a recommendation that I have read in which if your first line PPI doesn't work, it's probably justified to use another drug for a similar period of time along with other drugs and physical maneuvers to see whether you've actually truly run out of medical options or not.
So I've been told my time is up, but then it was such a wonderful discussion. Sir, any last comments?
If you
From
have
each one of
such
you.
a situation, you might want to revisit your patient and see what were his symptoms.
Yes.
What are you expecting out of? What was the diagnosis? Patient has abdominal pain, dyspepsia, and you expect PPIs to work, it will not. So,
I wanted to ask Dr. Arora.
I've had a patient who had eclasia based on endoscopy, fundoplication was done, and his symptoms worsened.
I wanted to ask Dr. Arora that based on this algorithm where you have typical symptoms, you have written EGD and manometry first and then pH. Should it be EGD and pH first and then manometry, or this and
Actually,
why?
happens, it's very short procedure as a manometry. So
Yeah. See,
Accurately place the pH.
with endoscope, require an endoscope.
And you will rule out any esophageal motility.
all patients undergoing fundoplication need to have manometric assessment for two reasons. One is to rule out a subtle incipient motility disorder like diffuse esophageal spasm or eclasia cardia, and also to look at good contractility. If you have tightened the valve with poor contractility, you are going to aggravate the dysphagia. That is the reason.
Such a wonderful afternoon, a high round of applause for the wonderful panelists we've had. And actually the surgeons and the physicians matched their weights today. So wonderful. I was so glad to have all of you here. Thank you so much, sir. Thank you, everybody. Thank you for such a patient listening.
Sirs, we do have mementos for all of you all. Sir, please come on the stage.
Request the panelists to be back on stage. And I request our ex-president, Delhi State Chapter, Dr. P.S. Sarangi, from head of the department, India Upadhyaya Hospital. No, sir, stage pe. To please hand out the mementos. May I please request him to give out the memento to Dr. Prabal Roy for such an excellent moderation for the panel discussion.
Thank you very much.
Dr. Prabal Roy. Photographs. Dr. Rajendra Prasad, sir, please. Dr. Rajendra Prasad. Dr. Anil Arora, sir. Dr. Sabya Sachibal, sir. And Dr. Sumit Shah, sir. This was one session where we had a lot of consensus among the physicians and the surgeons rather than an ongoing tussle. We had an amazing time, sir. Thank you. Dhanush.
Okay, that was a very nice session. Lot to know about the gastroenterologist and the surgeon's perspective. So the next session is on anti-reflux surgeries and fundoplication in GERD, key to doing it correctly. So to moderate this session, I would like to call on stage Dr. Arun Prasad. So Dr. Arun Prasad, sir, he is the Senior Consultant and Head Department of Surgery at Apollo Hospital, New Delhi. And as panelists, I would like to call on stage Dr. Ajay Kripalni, sir. Sir is the Senior Consultant and Director at Department of Surgery, Fortis Hospital, Gurgaon. Dr. Deepak Govil, sir. Sir is the Senior Consultant in Surgery at Indraprasth Apollo Hospital, Sarita Vihar, New Delhi. Dr. Manish Baijal, sir. Sir is the Senior Director, Max Institute of Laparoscopic, Endoscopic and Bariatric Surgery, Max Hospital, Saket. Dr. Parveen Bhatia. Sir is the Director of Bhatia Global Hospital and Endosurgery Institute and the ex-chairman Institute of Minimal Access Metabolic and Bariatric Surgery at Sir Gangaram Hospital, New Delhi. And lastly, Dr. Rajkumar Chajara. All right, sir is not here. Over to you, Arun, sir. Thank you so much, everyone.
Thank you and congratulations to the organizers to select such a nice topic, and we will try and take it further from where Prabal left. And there are two parts of this. One would be on how to select your correct patient and then how to select the correct steps. So to start with, of the diagnostic investigations, we have covered these, and I would like to start with, we'll start from Dr. Kriplani. I think one of our panelists is missing, so we'll skip. Okay. So how do these tests, which we discussed in the last panel discussion, influence your decision to perform fundoplication? Would you want all these tests in all your patients?
You see,
those patients who come to us with symptoms for the first time, the aim is to give them, put them on PPI for a trial period of 6 weeks. If they respond and the symptoms do not recur, then they do not need any further investigation. These are the recommendations of the American Society of Gastroenterology. If they respond partially, we make it dose double and again put them on PPI for another maybe 4 weeks. If their symptoms abate, then they do not need any further investigation. Investigations are required only in those patients whom we are considering for surgery, so that we choose appropriate patient, because it is very important that our surgical results will depend on these investigations, and it must correlate that we are choosing the patient properly. If the surgery is done in patients who are not the deserving candidates, we might make their life worse than what it was before surgery.
Quite right. I think that's a perfect opening statement, because this is what we will delve
So
upon.
these investigations are required only and only for those patients whom we are considering for surgery. High resolution manometry today is an essential investigation, particularly in those patients who either fail to after medical treatment or recur after medical treatment or have extra esophageal symptoms like bronchial asthma, neck pain, tooth pain, throat pain. Okay, these are the patients in whom we cannot be sure about, or those patients in whom the endoscopy is normal. So these are the patients who have typical symptoms, normal endoscopy. They don't have GERD, but they have what we call as NERD, non-erosive reflux gastritis, which will have symptoms similar to GERD, but we have to pick up these patients carefully so that we can help them by surgery, provided they fit in the shoes.
Quite right. I think that was a wonderful start. So, Dr. Govil, what we did mention in the last panel discussion also about D-Mister score. So, do you take the D-Mister score when you decide for anyone to go for fundoplication surgery?
Yeah, I think previously when these facilities were not very easily available, then we were not using, we were going more by endoscopy and symptoms of the patient. But now I think it's almost essential investigation before we take up the patient for surgery.
Sure.
So if the indications are there, we go in for pH studies and then the
Right. So that's a wonderful message. So whoever are the postgraduates or the junior surgeons, now please remember D-Mister score is become quite an important criteria, and a D-Mister score more than 14.7 is essential before you take up a patient for surgery. A few words about this scoring. Now this covers the percentage time where the pH has been less than 4. This is during the pH manometry, pH study. Then the percentage time with the pH less than 4 in the supine position, total percentage where the pH has been less than 4, and also the number of reflux episodes. So number of reflux episodes where the pH drops below 4. So these become all very objective criteria to decide before you take these patients for surgery. And finally, number of reflux episodes which last more than 5 minutes. So all of us, after a big dinner, like today after the conference, you're all going to have dinner. Half of us are going to go and have some kind of a GERD, but that does not mean that we are candidates for surgery. So we need objective criteria for this. And the longest reflux episode, finally, that also has to be measured. So all these data combined, your endoscopist or your lab is going to give you a D-Mister score. So next, Manish, would you want to have manometry in all your patients who you are going to do a reflux surgery?
So I think this is something we've been discussing for a while now. Manometry is absolutely an essential investigation. Now, when we talk about diagnosis, we stop at endoscopy and pH. Once you have a diagnosis of a GERD, you are considering a patient for surgery, manometry is a must because you want to look at the esophageal motility. You would like to decide as to what procedure you would like to offer. So
and what procedure you would not like to offer?
Absolutely. So manometry is a must.
Okay. So just to...
I just have one.
Yeah, please.
You see, this is true that previously the type of surgery, whether you do a 360-degree fundoplication or 270-degree fundoplication, depended on, in some centers on the motility report. But in the recent randomized control trials, it has not shown to be so effective, because we have to understand that besides primary motility disorder, in many patients there is pan-esophagitis. The full thickness of the esophagus is inflamed, and we see that during dissection that the inflammation has reached even the outer muscular layer. And in these patients there is a secondary motility disorder which decreases the gastric emptying. So now this statement is controversial. Some centers would do a toupee if the motility disorders are incomplete, but many centers, including ours, and there are many reports, say that if the motility is weak esophageal motility, what they call, the difference is only in the dysphagia in the initial 8 to 12 weeks, and after 12 weeks, the results of toupee and Nissen fundoplication are almost the same. So it is not a gospel truth that all patients who have weak esophageal motility will do better with toupee rather than fundoplication.
Point taken.
Because it is across the continent. You go to the North America and everybody does 360-degree toupee, and you go to Europe and 360-degree Nissen, and you go to Europe and their 270-degree toupee is more popular.
Okay, point taken. So what do we see in a esophageal manometry report? We see a few things. One is the LES pressure. So less than 10 is a hypotensive, more than 30 becomes hypertensive. And again, we also look at the LES relaxation, and we look at the esophageal body peristalsis. So these are the few things which are seen in the esophageal manometry report. And if we were to interpret together both our pH study and the manometry, we would look at a high Demister score combined with prolonged acid exposure that confirms reflux, and the manometry, when we talk about it, identifies motility disorders that may affect surgical decisions. For example, achalasia versus GERD, which I think we spoke in the last discussion also, and it ensures adequate LES function for fundoplication or identifies issues requiring tailored approaches, which is what we were just talking about. The next question, yeah.
I think manometry, I would also stress, also tells us about diffuse spasm or studies where we should not be doing it.
I'll come to that. So that's a separate question. Yes, I'll come to that. Dr. Bhatia, role of endoscopy in deciding. So we all, endoscopy is something which almost all patients have. But what are you looking at in the endoscopy report which helps you in deciding the patient's surgery?
I would say that before even talking about the role of endoscopist is more important. What I mean to say that in Gangaram Hospital, Dr. Anil Arora and myself, we work together in tandem, and we would love not to operate on a patient whom we can do more harm. So once we have a consensus, yes, this is the patient who has merited the surgery, so that's the way we go ahead. Now and at the time of endoscopy, I definitely want that he should tell us that is it a acid reflux or bile reflux or alkaline reflux? Is it a non-erosive esophagitis or erosive esophagitis, and whether there is a structural abnormality or not? So if these are present, then definitely it changes the mindset whether we are going to help the patient or not. My honest feeling is today we are doing more harm by doing the surgery rather than by not doing the surgery.
So I think that's one of the reasons why we are having this meeting today, and we will come to those questions also on when to avoid. So these days what we see, something which we were not seeing in our earlier career, is what is known as a Hills grading. And Hills grading helps us a lot when it comes to hiatus hernia requiring surgery. So we have talking about Hills grade 1, we have where surgery is not required and usually these patients just have medical treatment. We have a Hills grade 2 which may benefit from surgery if unresponsive to medical therapy. However, we also have Hills grade 3 and Hills grade 4 where surgery is of benefit. The details of the grading are written there. I think everyone can read it quickly. before I go on to the next question, which is what Dr. Govil brought to the idea, is we'll go back to Dr. Kriplani. When to avoid surgery based on pH monitoring and manometry tests?
You see, patients, those are not good patients for surgery in case patients who have, I would say, high-grade dysplasia with Barrett esophagus, patients with adenocarcinoma, patients with poor motility disorder like scleroderma, or all named motility disorders. Named motility disorder means achalasia, nutcracker esophagus, diffuse esophageal spasm. These are the patients who should avoid surgery, particularly high-grade dysplasia, because they will require a mucosal resection along with the Barrett esophagus and adenocarcinoma and scleroderma. You will make him worse, and scleroderma is a very tricky situation. And you must exclude morphological abnormalities like eosinophilic esophagitis. Because again, in eosinophilic esophagitis, the ministry of treatment is medical and not surgical.
Dr. Govil, you want to add anything? I think Dr. Kriplani has given almost a full list.
Covered mostly.
I'll just make a statement.
Yeah.
I think scleroderma is an absolute.
Absolutely, yes.
But
Disaster.
we were just discussing a patient that we had operated very recently. A 23-year-old gentleman, everything was ruled out, scleroderma positive, no esophageal motility with significant reflux and Barrett's. So we actually counseled the patient that only thing that we can offer is a partial fundoplication with a possibility of reversing if the patient becomes dysphagic. But the patient did extremely well after the surgery. So absolute contraindication, but at times you can offer. Sure.
Yeah, I think scleroderma, you should do a two-pit. You can do a two-pit if the patient's symptoms are significant. So that is acceptable.
Dr. Bhatia, anything to be added when not to operate?
Obese patients, I forgot. Patients with BMI of more than 35.
We'll come to that.
Yeah, more than 35, they should not have a anti-reflux procedure, they should have a Roux-en-Y.
We'll come to that question. You have reduced one question.
No, definitely. I think obesity is the right place.
Sure. Okay.
And one has to be very, very sure about ruling out the malignancy.
Okay, yes. So, when to avoid surgery based on pH monitoring and manometry test, I'll take a few minutes on this because this is a very important point, and as Dr. Bhatia also said, we can do more harm than good. So, if the D-Mister score is normal, that indicates that acid exposure is within normal limits, suggesting that GERD is not the cause of symptoms of this patient. Surgery is unnecessary and would not relieve symptoms. Negative symptom association probability. Now, if reflux episode do not correlate with symptoms, acid reflux may not be the primary issue, and surgery is unlikely to provide symptomatic relief. So that's where the gastroenterologist and surgeon have to evaluate the reports together. Predominantly non-acid reflux. So if there is reflux but the pH is more than 4, then what are we trying to prevent? Fundoplication is not typically effective for non-acid reflux. These cases may benefit from other treatments such as dietary modifications or medications. Then findings in manometry, those were the pH findings. In manometry, achalasia, which is a high pressure, or severe ineffective esophageal motility, where you have weak or absent peristalsis, then you have to consider avoiding surgery or opting for a partial fundoplication as we just spoke about. Then distal esophageal spasm, there again surgery may actually worsen the symptoms and is generally not indicated. Lastly, jackhammer esophagus or nutcracker, where high amplitude motility is seen. This is a very classic picture. Soon, even in surgical exams, these pictures are going to be there in spot diagnosis. So fundoplication is contraindicated there. Then hiatus hernia with very short esophagus. Again, there some other procedure like a collis gastroplasty might be needed. Absent lower esophageal sphincter pressure, complete loss of LES tone may indicate other disorders like scleroderma, where fundoplication is less effective and may cause complications. Here, as Manish gave a wonderful example, that is how we need to counsel the patient. So we come to the next question.
Arun, just before going that, I would say that good responders to PPI are good candidates for...
Yes, so that used to be the criteria in our postgraduate days, that if the patient has responded to PPI, then only operate. If they have not responded to PPI, they'll not respond to surgery either.
But if you see the SAGE's recommendations, SAGE's recommends that even PPI failures can undergo anti-reflux procedure, the difference being that the response rate is not as good as those in PPI responders, while in PPI responders the response rate is to the tune of 80-85%. In non-responders, it is still more than 50%.
I was mentioning our PG days, that's 30 years ago.
Yeah. So, but I mean, for a long time, we also used to teach that non-PPI responders should not be operated.
Sure.
But now things have changed. Now things have changed.
No, that's a very good
You can
point.
operate them, but knowing that the results will not be as good as in PPI responders.
Quite right. So now we will go backwards from Dr. Bhatia. How do you decide between a Nissen, toupee or door fundoplication based on patients' symptoms and all the investigations which we have done?
I would put it this way, that we would go in for investigations and we find that manometry has as partial obstructive motility disorders, then I will reserve the toupee for that. And if there is no motility disorder, then I will go in for 360-degree Nissen fundoplication. And if I am doing the, for example, ecclesia cardia, which is outside the domain of this, then I am doing the DORS fundoplication.
Very right. So just a very quick recap. Yeah, please.
See, DOR is exclusively for achalasia.
Achalasia.
I mean, it's not for fundoplication. The difference between dysphagia and gas bloat syndrome, which is the main reason why we choose between Nissen fundoplication and toupee, is that, Nissen is associated with higher incidence of gas bloat and dysphagia. But there is a lot of importance of technique also. Mobilizing properly the short gastric, making a short floppy Nissen, making a short Nissen. It has been shown that if your toupee is more than 3 centimeters or less than 3 centimeters, it does not affect the incidence of dysphagia or gas bloat. But if your Nissen fundoplication is less than 3 centimeters and more than 3 centimeters, then it significantly increases the incidence of gas bloat and dysphagia. So less than 3 centimeters of Nissen fundoplication perhaps in the long run has the same gas bloat syndrome and same dysphagia as compared to the DOR. So, it is important that you should do a short Nissen, you should do a floppy Nissen by properly mobilizing the short gastric vessel. In the early short-term dysphagia might be more, but on the other hand, the recurrence of reflux is definitely more with toupee allowed than compared to Nissen fundoplication. So all these factors have to be captured.
Yeah, just a small, that DORS, yes, for ecclesia cardia, but there are situations, and I am going to present my one small video clipping which I have got it from one of my friends. He had injured the anterior part of the esophagus when he was doing the Nissen fundoplication. He planned to do, but at that time, because the anterior longitudinal muscles were injured, so he completed the DORS.
So just to quickly recap, I'll run through this. We will do a Nissen in severe GERD, good ability. Advantage is that it's the strongest control, and limitations are that it has incidence of post-op dysphagia, gas bloat, and you should avoid it when esophageal motility is weak. And we talk about toupee. Again, mild to moderate, patients who are prone to dysphagia, and it's a compromise when you don't want to do a full wrap. Advantages are low risk of dysphagia, but limitations are it is less effective. So when to avoid, you should avoid this in severe GERD where complete reflux control is necessary. Lastly, DOR, as we all agree, this is an adjunct to Heller's myotomy, and these patients' advantages are that it has minimal risk of dysphagia, simpler quick procedure, but it is the least effective of all. When to avoid severe GERD requiring strong reflux control. So now we'll just go through a brief video and then we'll talk about the technical steps after that. So the steps may not be the same which I am doing, but probably we are talking about the same thing. What I do is I start with the short gastrics because I feel that mobilizing this is very important to have a tension-free procedure, and a lot of people would come to this last, but ever since we have been doing bariatric surgery, I have got used to doing this first, whereby I release the short gastrics, free it from the spleen. Then another step is to go into the pars flaccida, which is the classical start most people would do. And cross over to the opposite side to expose the left crus. Free the esophagus. Now you should have at least 5 centimeters of intra-abdominal esophagus free before you proceed with the further procedure. And any adhesions posteriorly have to be divided. And like any other minimally invasive surgery, window is most important. So just like you make a nice big window for your cholecystectomy, you would need a good window here so that the fundus goes across without slipping back when you leave it. There is a shoe shine maneuver where you can again reconfirm that it is nice and free. Now these are steps of a robotic surgery, but the steps are exactly the same if we do laparoscopic procedure. Closing the crura. Now I would like to not make it very tight, because closing the crura tight can cause dysphagia, and I don't think that is the primary way of repairing. It's the fundoplication which is more important. So if you can see there is a nice big hole in under the crura right on the top to allow for bulky bolus of food to go across. 3 stitches is what we do, and one of these bites also goes through the esophagus to prevent it from slipping back. And usually it's the second bite which we take from through the esophagus like that, and then there is a third bite below. It should lie nice and free. Okay, I think that's the end of the video. We'll go back to the questions. Niche, no?
Panel.
So my next, I think Manish was next on the line, which is how to exactly identify the GE junction as a surgeon. So I think for people who are starting off, that is the first challenge which they get, that how do you identify? After doing many surgeries, it becomes easy, then it becomes very obvious. But what advice would you give to the beginners as to how to start? How do you identify the GE junction?
So in cases of large hiatus hernia, you're not going to see the GE junction. It is migrated into the chest. So you have to mobilize the esophagus, get an adequate length of esophagus down. You will always have a Belsey pad of fat there where you can identify the GE junction. But I think in a normal anatomy, it's very apparent as to where the GE junction is. There is no clear-cut rule as to what can guide you that this is the GE junction, but in aspect of anti-reflux surgery, adequate mobilization, getting the esophagus down, that's when only you can identify.
So Govil, any tips on how to find the right spot?
I think it's quite evident, mostly the structure of the esophagus, the longitudinal muscles, and suddenly they splay onto the radial muscles.
And the pad of fat, as you mentioned.
Yeah, I think these are the things.
There are actually 3 points by which you identify the GE junction. But these points differ in normal individuals and in hiatus hernia. In the normal esophagus, angle of His is a very important point where the GE junction remains. But in a large hernia, as Manish said, it migrates, so the angle of His becomes less acute. Second is where the tube flares up into a sac. You know, the esophagus is a tube, and then it flares up into a sac of stomach. But that also can change along with a large hiatus hernia. So the most important indicator for GE junction remains, whether in normal anatomy or in hiatus hernia, the peritoneal reflection. The peritoneal reflection, even despite a large hiatus hernia, will stay where it is. So the portion that is not covered by peritoneum is esophagus, and the portion that is covered with this peritoneum is stomach. So you have to find that junction where the peritoneum is reflected, irrespective of it is a normal anatomy or it is a large hiatus.
Good point.
Small point is about the attraction. One has to hold the height at the fundus.
And and pull the fundus down. Yeah. So Dr. Govil, what is your strategy for determining the optimal length and tightness of the wrap?
I think it's routinely we do a standard around 3 centimeter size of the wrap. That is what we decide, and we mobilize the short gastrics in majority of the patients, mobilize the greater curvature with short gastrics, and then we determine that 3 to 4 centimeters should be the wrap, and then we put 3 sutures. That's the.
So Dr. Kriplani, how many sutures and where exactly do you put? And are there any additional sutures to prevent wrap migration?
We are talking about sutures on the crura?
On the wrap.
On the wrap.
On the wrap, yeah.
On the wrap, it is 3 sutures, 1 centimeter apart. So it is 2 centimeter wrap. So it should, this also depends whether you are doing a toupee or you are doing a nascent fundoplication. In toupee, perhaps maybe you can take a little larger wrap because the anterior portion of the esophagus is open. So even if you make a wrap of more than 3 centimeters, 4 centimeters, it is okay. But in a nascent fundoplication, the wrap should never be more than 2 centimeters. It is very important. Otherwise, the longer the nascent wrap, the more the chances of dysphagia and the more the chances of gas bloating.
Right.
And the second part was?
Second, that do you put any additional, any hitch or anything else to prevent the stomach from
we
slipping
believe
back?
that one single suture cannot prevent migration of the wrap into the mediastinum. We rely more on extensive mediastinal dissection. I mean, we make it a point to demonstrate the inferior pulmonary vein minimum in every patient of nascent fundoplication. So a very long, very far off mediastinal dissection, and even in patients whose G junction preoperatively was at about 28 centimeters and we were prepared to do a cholecystoplasty. By extensive mediastinal dissection, we could bring it down into the abdomen. So the key lies in mediastinal dissection and not a hitching suture, which is hardly of any consequence. And secondly, your wrap should be bulky. The suture that you take on the wrap should not be on the anterior surface of the fundus, but they should be on the posterior surface of the fundus, which is coming from behind the esophagus. By that way, you make a very large, very bulky wrap, and you leave the mediastinum equal to double the size of the esophagus. So you leave less space on the hiatus, you make a bulky wrap, and that should prevent the
It's like a big ball there.
It's like a big ball which cannot go.
So going back to Dr. Bhatia, any release incisions on the crura?
Before going in for releasing the crura, you had also not put the U stitches or mattress sutures on the crura. Normally, we would put in the mattress, horizontal mattress or vertical mattress on for the cruropexy.
Yes.
Definitely, yes. And our thoughts are that if the crural defects is more than 4 centimeter, we may place in a mesh. But if it is too thin a crura, then release also would not help much.
Okay, so any role of release?
There should be.
Any role of release with the crura, or we don't do? Nobody does.
I don't think.
Extremely rare. Okay. I may have tried on the lateral border of crura on both the sides, but
you would rather put a mesh than
yes, I would rather put in a prosthesis.
If you see the anatomy, pathological anatomy of the nascent fundoplication, you will find that the right crus never moves. Whenever the hiatus dilates, it is a left crus which goes further off and further off and further off. So whenever you try to close the crura and you feel that there is tension on the closer, then one option is to give a release incision medial to the right crus of the diaphragm, close the hiatus, and then put a mesh. If you're given a release incision, then you have to put a mesh so that you cover not only the crura but also the relaxing incision. But the other option also remains that you can put a onlay patch on the unclosed hiatus. But we believe that giving a relaxing incision on the crura and covering the mesh perhaps sound physically stronger than putting a patch on the unclosed hiatus, because the mesh itself can migrate into the mediastinum.
Like an iPhone Plus.
Yeah.
In the same vein, as Dr. Kriplani was also mentioning that we should mobilize up to the inferior phrenic vein, agreed. Good mobilization is a must, but still we definitely fix the wrap onto the right crus as well as to the right crus or to the left crus by one suture each, because we have seen the wrap migration.
Okay.
So these are all happiness sutures. Actually, if you look at the guidelines, they never talk about putting those sutures. But yes, if you feel
Makes you
more
feel
confident by placing them, you can.
You see, there are so many things the surgeon does because he feels happy doing it. So, because surgeon must feel happy at the end. Yeah, at the end, the surgeon should be happy that he has done a good job according to his own assessment.
And I think
It
mobilization,
can't do any harm, I think.
It can't do anything.
and
Agreed.
mobilization I think is important, and
Yes.
robotically you can really go deep
Sure.
into the
I'll come to the robotic question. So I think who was next? Manish was next. So do you use intraoperative tools like bougie, endoscopy or manometry during the procedure?
None of these anymore.
Okay.
So intraoperative, there was a time when we were taught how to do hiatus hernias to prevent tightening of the wrap.
So keep a
We would,
bougie.
yeah, put a bougie, but we do not use that anymore because you make a floppy wrap. If you mobilize your fundus well, you have mobilized your esophagus well. That
So as we are not doing things very tight,
Yeah.
we are not using it. Anybody uses
So
any of these aids?
intraoperative endoscopy at only time when we are doing revisional surgeries.
So you want to rule out-
So it also
rule out
works.
the perforation.
It also works as a bougie. It guides you where the anatomy is. Otherwise, in a primary surgery, none of these three.
Our thinking is you cannot manage what you cannot measure. Because we are trained to do these bouginage in sleeve gastrectomy, so we definitely rely on the people on the other side. And we do use the bougie, but at the time of suturing, closing, we ask them to withdraw and again, don't allow them to pass it again.
You see, bougie has very high chances of perforation. If you see the anesthetist when the patient is in leg slit position and is down, and the anesthetist is putting a bougie, and sometimes some anesthetists have the mind of their own, and they do not coordinate. It has to be properly coordinated between
You
the
have to actually
surgeon.
straighten the stomach before you allow
Yeah.
them to push
So,
it in.
and particularly what happens that after you have tightened the crus, the angle of the bougie becomes more oblique, and the chances of perforation are much higher. So only in my first distant fundoplication I put a bougie, but the way the anesthetist was putting the bougie, from the next case I didn't have the guts, to ask them to put a bougie.
So now, Dr. Govil, you were mentioning. So now we'll come to technology. What is the role of robotic surgery? You think robotic surgery gives you a better option of doing fundoplication? You think it's the same?
Yeah, I think it makes, at least I feel much more comfortable doing it robotically, because the dissection in the mediastinum to dissect the esophagus, mobilize the esophagus is much more easier. Suturing obviously is a relatively more easier with the robot, so I feel much more comfortable. But I think it's a technical
It's a
thing,
personal choice. Dr. Kriplani, ICG. Would you use ICG in
No,
fundoplication?
we don't use that.
Anyone, any role of ICG?
So the only indication in we had a patient with a large paraesophageal hernia, volvulus, and it was gangrenous at certain points. So we actually had to do a sleeve gastrectomy in that patient not a sleeve gastrectomy, but to resect that part of the stomach which had doubtful vascularity. So in such patients would like to see the ECG and look at the staple line.
Dr. Bhatia?
Yeah, there is a role of ICG, especially when the wrap migration has occurred. And maybe next very day you find that wrap has migrated, so one should always see the vascularity. If it is well maintained, then you undo or do
So
or whatsoever.
complicated cases, redo cases.
It
things like
definitely helps.
that. Last question, Dr. Bhatia, for you. Role of mesh?
As I mentioned that if the hiatus is more than 4 centimeters, if the crura are very thin, they will not be able to approximate. Even if we are using the pledgets, definitely one goes in for the mesh. But initially, all of us had used the crura patch and so many meshes, but one should be refraining oneself not to use the Prolene mesh directly onto the esophagus.
So which mesh would you prefer these days?
The Phasix mesh is being
Phasix
done.
mesh.
Yeah.
Dr. Kriplani, large hiatus hernia and the crura are attenuated. What would you do?
You see, the definition of large hiatus hernia is when the crura is more than 5, the hiatus is more than 5 centimeter in size, or the 30%, and some people say 50% of the stomach is lying in the mediastinum. And if the crura is attenuated, then first you try to close the crura with what Praveen said, with the U stitch using pledgets. So you see whether the pledgets are holding. Otherwise, you have the option of reinforcing by a mesh, which should always be a PTFE mesh. It should not be a biological mesh, because biological mesh we have used and has shown that with passage of time, the efficacy of biological mesh keeps on decreasing. Proline mesh is an essential no. So only a ePTFE mesh, giving a relaxing incision, covering that area and the closed hiatus with an ePTFE mesh. You can use a horizontal patch, you can use a circle 360 degree. I mean, there can be so many ways, but you should always cover the hiatus as well as the relaxing incision.
Dr. Gobil, ePTFE or Phasix?
EPT.
Anybody?
So ePTFE is just a barrier, and using pure ePTFE is you are looking at recurrence. So either it's a composite in which you have a ePTFE or something else on the other side, or a Phasix mesh, which is a good option.
Another important thing is not to use staples, not to use tacks, because people have died of cardiac tamponade when the mesh people have been trying to fix with the Protac. So, and multiple deaths have been reported because of cardiac tamponade. So the mesh has to be fixed with sutures. And we have so far experienced with only ePTFE. And we have been extremely happy.
Only ePTFE?
ePTFE meshes.
Still you are using it?
Yeah, we are still using it.
Right.
For hiatus hernia.
Yes.
For hiatus hernia.
Yeah.
Only for hiatus hernia.
We had used in the initial phase of our experience, but literature also does not support the ePTFE, and we are using Phasix only.
Literature supports ePTFE.
I think more and more people are moving towards Phasix.
Phasix.
Is my
Phasix is just 2 years old.
Yeah.
Phasix is not a very old mesh.
Maybe they are doing good marketing.
This appears to be a good indication, because you are talking about an ideal situation, if there is one, that there is a mesh that gives the strength and then it disappears. Okay.
So
So
Manish,
it's an ideal situation.
last question for you. Shortened esophagus, what would you do?
So shortened esophagus is something which is a very, very rare entity. If you mobilize the esophagus well, as Dr. Kriplani spoke about at 28 centimeter G junction, and he could get it down, that is the scenario in majority of the cases. So shortened esophagus, I would say we would have done a Colles gastroplasty, one in probably 1,000 patients. It's extremely rare.
Any questions or comments from the...
There's one thing I like to say about short esophagus. Please remember, short esophagus is an intraoperative diagnosis. It is not a preoperative diagnosis. Whatever it may look, the G location of the G junction, an extensive mediastinal mobilization will invariably bring the G junction. So only after extensive mediastinal mobilization, you fail to bring the G junction into the abdomen, only then you label it as a short esophagus, not on a barium or not on an endoscopy. And secondly, these cholecystoplasty, these pictures look so good on the papers, you know, but when you go to do them, please remember that whether you do a total intra-abdominal cholecystoplasty or you do a combined thoracoscopic and intraperitoneal gastroplasty, the leak rate at the junction of the vertical fire and the horizontal fire is real, because the stapler, the way they are fashioned, the last portion of the stapler does not contain the staples. So leak is a real possibility, and even intra-abdominal you can do it only with a GIA stapler, or you can do with a combination of EEA and GIA stapler. So please remember, they look so simple, they look so exciting, but the leak rate is very high, and these patients post-operative, you should always do a gastrographin study on day 1 to make sure that no leak has occurred, and only then you start
I've
them.
avoided these complex questions. This was only one.
Yeah.
I have not talked about revision also. So maybe it's for another meeting
No,
elsewhere.
it's very exciting, to see these pictures, but they are very tough to do.
So I just wanted any comments. We've got a lot of experts and experienced people here. Dr. Ratna, Dr. Srivastav. Anyone who would like to make any comments or any questions before we close?
Arun, I just want to add, I think it was probably covered in the last panel also, as regards barium swallow. Actually, initially we were doing barium swallows, but now we've shifted to CT with a on-table
CT
gastrography.
gastrography.
Yeah, that's
Arun,
a much easier thing to...
one last statement. I think in all these two panel discussions, we've talked about working up of the cases. There have been times you've seen patients coming to your clinic who's been visiting a gastroenterologist clinic for a while with multiple endoscopies, symptoms, treatment, never advised an ultrasound. So I think ultrasound should come very high up in the initial workup of these patients.
You might be having gallstones. Sure. Thank you very much. That was a very wonderful discussion and it was a learning experience for all of us. I hand back to the organizers.
Thank you so much, sir, Arun sir, and all our panelists for giving us such a panoramic view of the surgical management of GRD, particularly fundoplication. I would request Ashish sir to please come and present the mementos to us, to the panelists.
I request Dr. S.K. Poddar sir, past president of the Delhi State Chapter of ASI, to please come on the stage and honor the panelists and the moderator with a memento. A memento to Dr. Arun Prasad sir for excellently handling the panel discussion and keeping us engaged with such interesting questions. Thank you so much. Dr. Praveen Bhatia sir.
Thank you very much. Thanks. High profile panel.
Dr. Deepak Govil. Dr. Ajay Kriplani sir. Dr. Manish Bajal sir.
Thank you very much. Thank you very much.
Okay, so now we are going to proceed to a very interesting session that is life beyond surgery. And I think all of us always have questions related to this session but don't know how to approach to having a life beyond surgery. So for this session, I would like to call on stage Dr. K.N. Srivastav sir. Sir is the Senior Director and Advisor, General and Minimal Access Surgery at BLK Max Super Specialty Hospital. Thank you, sir. Next, I would like on stage Dr. V.K. Malik, sir. I believe sir is not here. Dr. Ratna Chopra, ma'am. Ma'am is the Head of Department of Surgery at Hindu Rao Hospital and North DMC Medical College, New Delhi. Thank you so much for coming, ma'am. Next, I would like to call on stage Dr. Professor Chintamani, sir. I believe he is not here too. And Dr. Neeti Kapoor, ma'am. Okay, ma'am's not here. Right. So now I would like to call on stage Dr. Ashish Dey to really get all of us into that zone of life beyond surgery and invite our chief guests. Thank you.
May I request Dr. Harish Gulati sir to please be there as a chairperson, and Dr. Tanveer Karim sir, please be there on the dais. So it has all been about academics till now, but we have a short session on life beyond surgery where we'll talk you on two topics. Like we as surgeons are very poor about how to manage our money. And it is important to know how and where to invest, how to invest, what exactly to invest in. And for that interesting session, I have Mr. Anuj Gupta. He's from HDFC Bank, and he has been a prolific speaker. So let me introduce you to him. So he is the head of commodity, currency and derivatives. He has more than 18 years of experience. He has been appearing regularly on many business channels like CNBC, Z Business, ET Now, NDTV Profits. And he has been tracking all the financial and the markets globally. So without much ado, I'd like Mr. Anuj Gupta to please be on stage. Thank you.
I think after a core academic session, probably it was very much desirable to have some light session. Of course, that is also equally important because anybody and everybody is, after academics, he needs some money also.
Definitely, sir.
So Anush, please carry on.
Thank you very much, sir. So good evening, all of you. Thanks to giving me this opportunity to, discuss on the topic surgeon and money matters. So matters are always important because it might be a matter of medicine, health or wealth, right? So in my knowledge, health and wealth are, walking parallelly. If you have a good health, then you can easily, make a wealth. And if you have a wealth, then you can easily maintain your health. Am I right, sir? So, every time we have seen that people are looking towards the wealth, right? So wealth is, very important. While we are, earning any single penny, so we are trying to, accumulate this money and, increase in a percentage way, right? So at the current market scenario, there is a very good opportunity in the market because if you see that there are lots of product in the market which is very important and definitely people will invest in this market to create a wealth. So now my name is Anuj Gupta and I am from HDFC. I think no need to give introduction about the SDFC. I think everybody knows about the SDFC. So let's start my presentation which is based on what are the product available in the market and what are the good opportunity to invest to create a wealth, right? So my agenda of this presentation is ECG of market, trend analysis, investment opportunity and investment product. So as I mentioned that ECG, in my knowledge, ECG is basically used for to judge the heart of a human being. Right, sir? So ECG of market means when we talk about the market or if we talk about any investment, so it is related to the volume of the market, right? How people are looking towards this product and how people are looking investment in the product. So right, if we talk about that market is looking positive, so everybody is looking towards the bullish side, positive side. So that is called as the volume, right? So when we talk about the ECG, the ECG is very important for a human being and even ECG is also very important for the investment. So right, this is the agenda of this. So life is starting from the born of a baby, right? So when we talk about the investment, so investment journey is starting from the IPO, right? So IPO is a initial public offering. So when we start my first investment or somebody start their investment, so they are looking towards the IPOs. And if you see the historically in 2024, almost 327 IPOs came in Indian market and almost they give almost 16% kind of, right? If you see in the US market, there is a 183. So if you see, compare with other nations, India is the only economy where we saw a huge number of IPOs, right? So there is an opportunity where we can start investment from the IPO side. And if you compare the return of the IPO versus index, right? So you will see that IPOs every time give a good return. And if you see in 2024, almost 95% IPOs gave a very handsome return. Almost you can say 3 times, 4 times kind of investment, kind of return they gave. So IPO is a very important product when we are talking about the initial investments, right? So if you see, if you compare with the the index is not giving us so much kind of return. So if you see from 1st Jan to this time, index is almost flat. But if you see the IPO return, it is again giving very phenomenal return. So IPO is the initial investment where we can start our investment journey if we are, suppose if we don't have a demat account or kind of thing. So this is the initial offer where we can start our investment by investing in the IPOs, because they are giving a very good handsome return as compared to the other product. In 2025, what are the opportunity available in 2025? There is a lots of IPOs which are coming in 2025. One is the HBD, which is the parent company is the HFC Bank. Hero FinCorp, which is again the parent company of Hero Motor Corp. Reliance Jio, parent company is Reliance Industries. So you will see there are lots of IPOs which are coming in 2025, which is and these are all big shot IPOs. So if you see, and if you analyze these companies, so these are always also large cap companies, or we can say the blue chip companies, right? So this is the opportunity where we can start investing. If we didn't invest in single penny in this financial market to create a wealth, so IPO is the product where we can start investing to create a wealth, right? Another product is the unlisted. This is a product which is prior to the IPO. Unlisted means those stocks which are ready to launch their IPOs but still not listed. So unlisted is again a product where we can start investing before comes to the IPO. Just like NSE, this is a stock which is people are investing in the NSE before the IPO. It's still not, IPO is not available in the market, but people are investing in this unlisted, right? So there are lots of stocks which are available before the IPO. You can start investing in the unlisted stocks. So this is again an opportunity where you can create a wealth by investing in this product. So every time we are talking about the FIIs, right? Today we have seen a good budget where our finance minister is gave a budget to revival of the FDI, right? We have seen that today they are increase the limit of FDI from 74% to 100% in the insurance sector. So you can say that is again a part to revival of the FDI and FPIs. So if you see in 2024 almost more than 1.5 lakh crores FPIs outflow we have seen in 2025. So increase the inflow in the market. They are giving a ease of doing business in this financial market by investing, by inviting the FDIs. So this is again opportunity. And if you see this chart, this is showing that we saw a outflow in 2024, but now market on a very accumulation zone. And after the taking oath by Mr. Donald Trump, so now FPIs and FDIs are looking towards the Indian market, because Indian markets are again looking a very good opportunity as compared to the China. So if you see, there is a lots of tariff war between US, Europe and China. So India is the only country where we have seen a very good relationship between India and US. So this is again opportunity. If we are looking towards the Indian market, it means there is a good opportunity even for the FPIs also. So FPIs, we are expecting that now they are come with the good inflow in the Indian market that will provide support to the Indian market. So FPIs again we are expecting after this budget, now FPIs will look towards the Indian market for the investment. So again, this is the FPI have started short covering, right? It means they made a short in the market. Now they are covering their shorts. So it means covering shorts means now they are looking optimism in the Indian market. So that is a graph which we are seeing that market is looking a very lucrative way where people are investors are investing. So why I'm showing this screen, because it shows that everybody is saying that market is on a negative trend, market is on a downtrend. So people are expecting now market to be or girega. So now I'm, when I look this screen, it shows that market on a very short covering zone. Now investors, new investors, traders, and other stakeholders are looking this market in that way. Even a layman cannot see this graph, but yes, if an expert, or you can say if you are looking the market, then you can easily understand how the market is looking in the coming days. So now this is again graph which shows that where people are creating a long build-up. Long build-up means where people are looking towards the positive trend. So if you in this graph, we have seen that the only cement sector and technology sector and also the telecom sector, people are making a lots of long build-up. Long build-up means they are expecting a positive trend. And if you see from last 4 or 5 days, we saw a very good run up in the cement sector, right? So if that is a one way, another way to look to the market. So as compared to the 2024, we have seen a positive, almost you can say a long build up in the market in these sectors. So these sectors are, looking a very positive for, if you are investing in a long-term perspective. So that is again, opportunity to trade or to invest in the market. So one thing is that generally we are saying that the trading and investment. So trading and investment are both different things, right? So if we compare the trading is basically a short-term perspective. But if we talk about the investment, so why we do investment? To create a wealth. So my agenda is to, provide you some kind of, the showing the this chart to give you an idea to investment for creating a wealth for a long-term perspective. So in the market, what are the general investment? Just like you can say a stock market is a general investment. Also bonds, mutual fund, real estate and ETF. So stock market, as you know that when you purchase a equity in a particular company by the exchanges or by the private equity, that is the stock investment. Bonds are given by issued by the government or the companies. That is again a product to investment. Mutual fund, as you know that the total market AUM is almost 60 lakhs crore, which is on a very higher side, and now people are investing in the mutual fund by lump sum or the SIP. So SIP is also a very good product where we can start investing, or you can say create a wealth. I think you definitely heard about the power of compounding. So power of compounding is to basically works on the SIP. So if you are start investing in buy through the SIP, then we will see a huge wealth creation by down the line of 5 years or 10 years. That is the power of compounding used in the SIP form. And again, the real estate, as generally we are saying that real estate is only the investment purpose as we need. We cannot invest and we should not invest more than our need in the real estate, because real estate is a very big topic, and also it is not easy to feasible buy or sell at any point of time. So I think real estate is a very not easy to trade in the real sector. ETF is again a new product to investment in the market. So ETF is the exchange traded fund where we can invest electronically in different products. ETF is basically if we want to invest in US, we can invest in by using the ETF. We can invest in the US. If I want to invest in China, then I can use this ETF. If I want to invest in gold, then I can choose this ETF to invest in the gold. So ETF is a product where we can invest everywhere in the globe by using the ETF. So basically ETF are the exchange traded fund which are available on the exchange website, right? So this is again a very good the product where we can choose to investment. So as the classification, stocks are higher risk, higher return, right? So if I can able to make profitable trades, or you can say if I am able to get a risk, then I can invest in the equity market. So simple formula is that how much amount I want to invest in equity, 100 minus your age, right? If suppose I am a 40 years old, so I have to invest 60% in my equity and 40% in the traditional product. Traditional product means FD, traditional products means post office, and traditional product means anywhere you can invest. But if I want to create a wealth, so that is a formula. I can use the 100 minus the age. If suppose I am a 60 years old, then I can invest only a 40% in equity and 60% in traditional product. So that's why equity is always a higher risk, higher return, because it's totally based on the market movement, right? Or you can say international reasons or domestic reasons. So these are totally depend on that. Fixed income bonds, which is a guaranteed product, and you can say by investing in fixed income, we can get 7 to 8% or 9% kind of thing. As in today budget, we talked about the inflation of 4.8%, right? And India GDP is almost, you can say, a 6%. So if I'm getting a 10% kind of return from any product, so I think this is not a good product, because automatically I can get 5% from the inflation and 6% from the Indian growth. So if I'm able to get more than 11%, 12%, 13%, 14%, so that is a good product to investment. So I have to be clear that if I'm investing in any product and this product give me more than 12, 13%, so that is a product where we can at least can fight with the inflation and fight with the growth of any economy. So that is a good product where we can choose. So that is a, the basic criteria to how to choose the investment product for investment or to create a wealth. Again, a real estate, this is a tangible asset, and generally people are investing in real estate for rental income or for the price appreciation, because we cannot sell real estate overnight. So that is again a challenge for the real estate, and even I cannot get a desirable price in the real estate. So that is again a challenge for investment in the real estate. Mutual fund, this is a very good product to investment. So if I want to create a wealth for the long term, let's say for 5 or 10 years, then I can choose the mutual fund. So everybody, I think, know about the mutual fund, which is where a professional fund manager manage your funds. If you are good to manage the fund, then you can start equity. But if you are not good or you don't have a time to, churn the portfolio or manage your portfolio, then you can give your money to the professional fund managers, which are SEBI registered, right? So that is a mutual fund, where fund manager manage your funds very efficiently and which recorded by also the SEBI. So right, this is again opportunity where we can look toward the mutual fund. There are lots of mutual fund, large cap, small cap, mid cap, and even sectoral fund also. Pharma, there is a lots of pharma, mutual fund also where we can invest to create a wealth. And the commodities, I think everybody is like the gold. How many here like the gold? How many here like the gold? So gold is a product which is, today is at lifetime high. Anybody can say that what is the price of gold today?
75 or 80
Yes. 85,000 per 10 gram. And this is the only product which is increasing from very first day of 2025. एक तारीख से ये लगातार बढ़ी रही है. Right? So you can compare the actually value of the gold. And if you see or if you compare the gold return from last 100 years, it is increased by 8% compounding. पिछले 100 सालों से ये 8% compounding बढ़ी रहा है सर ये. So, yes sir.
But there is one irony, you will never sell it. You earn the gold, you never sell it.
Yeah.
And the asset is one which rotates. So gold, for that purpose, it is for the indicative purpose that your wealth is growing by 20%, 30%, but actual terms, it never comes as a money or cash. So this is the limitation with the gold. Yes, it is growing, but not in, practically usable form.
Sir, little bit, but right now, if you see the demand of jewelry, so now gold available in different forms, right? If you want to invest gold for usage, you just invest in the jewelry, right? So jewelry is a dead asset, because I am not sell my jewelry of my wife, right? So it is a dead asset. But if I want to invest in gold, so there's a lots of form. One is the physical gold in the term of bar. You can buy the bar from the jeweler, or you can buy a gold from MCX, and even you can buy gold through the ETF, which you can kept in your demat account. Then you can sell it, right? But if you invest in jewelry, so it means that's a dead asset. If you compare, US holds are almost 10,000 ton of gold. But if you check the household gold holding by the Indian, that is almost 35,000 ton. It means if as per the WhatsApp, university, if you sell all the gold of India, the petrol price will be 1 rupees per liter. Probably we have heard this so that is again a part. See, so gold is a product where we can invest not 100%, but yes, if I invest in 80% in equity market, so I can give 20% to the gold to basically hedge my portfolio. As it's proved in this year of 2025, in the first month of that, from 1st Jan to 30 days, gold gave almost 7% kind of return, but equity didn't give that kind of return. So we can use gold to only hedge the product, right? Suppose अगर मैं 100 rupees investment कर रहा हूँ, तो I can invest 20% to hedge my portfolio, which is a very important little bit. Again, the cryptocurrency, people are investing in the crypto, but it is not legal in India, right? If you can fight with international players, then you can choose the cryptocurrency. But we are not advising to invest in crypto because it is not legal in India as the SEBI mandate. So this is a screenshot of ETF. So gold ETF is trading around 69 rupees, silver ETF 88 rupees, Nifty 50 ETF is 256 rupees, Nasdaq is 207, Hang Seng is 346, Nifty at 49. So by paying 1000 rupees, you can invest in each and every sector. You can invest in commodity ETF, you can invest in US ETF, you can invest in China, you can invest in domestic market. So ETF is the product where you can invest in different economies, different product without any expiry. It can hold in the demat account, right? So there is a no limit. You can buy this ETF and hold your demat account till whenever you want. So that is a product where you can start investing in that way. So means by paying only 1000 rupees, you can add this product in your portfolio apart from the equity, right? If you are directly investing in Nasdaq, it means you are totally betting on the US market. If you are investing in Hang Seng ETF, it means you are betting on the China economy. If you are investing in Nifty, it means you are in the Nifty market. So this is the performance of ETF, global ETF, and this is the performance of debt and commodity market ETF. And the last product is the global investing, right? Everybody is like to invest in US. So just like Netflix, Microsoft, Amazon, Starbucks, Meta platform, Tesla. So global investing is another product where you can start investing this product. So why we choose US market? Because after the coming the Donald Trump, we are expecting a positive trend may be seen in US as they put tariff on European market to not to launch another currency. So we are expecting a positive trend may be seen in US market, and possibly US will breach all the other nations indexes. So US is looking lucrative for us also. If we are able to invest in US stocks, then we can definitely choose or add in our portfolio. Again one is the margin trading funding. This is again a product where we can start investing by taking some leverage from the broker also. So that is a little bit of product where if you want to do investment through the margin trading, this is a facility basically. You can choose this margin trading funding by taking some borrow money from the broker. And this is the the final gold price. If you see on 1925, gold was trading around 18 rupees 75, and right now today is 82. Thank you very much. Thanks a lot.
I think very interesting topic for the day, and I'm sure there may be many questions from the floor. Please come up.
So any query, please ask.
From my side, I want to ask, what is the take-home message for the young doctors who are having few bucks of money in their pocket? What they should do to be in millionaire after 10 years? So how they should approach?
See, sir, first of all, as I said that 100 minus your age, that is the first formula. If you are start earning, right, so just you minus your age and you start looking towards this market for an investment opportunity, you can start equity market, because equity is the product where you can create your wealth by investing direct equity or by investing through the mutual fund or by investing in through the ETF. So these are the three products where you can start investing in the equity market. So as you all aware about the, some people are saying that I am not investing.
Okay. With little understanding of this, I can just give message to my young generation. The first of all, you shall be focusing on your prime objective. Everybody wants to make money in life, and that too in quick succession. But that is not a reality. There is no gain without pain. So most of you who are venturing into the equity subject must be incurring losses. Definitely, 9 out of 10 you will, but this is because you do not have that kind of patience and understanding of the subject. One thing is earning, the second part which is more important is the saving. So that you should learn from this point only, and the basic is that you should have that patience of keeping your money in the equity market and invest in the large cap companies which are debt free. Okay, and then have the patience of keeping this money for at least from your you have a life expectancy of another 60, 70 years, to keep it for 10 years. And then you see and enjoy your life. I think there is no shortcut in the equity market, but it has a great potential, and that is 100%. I myself have that experience of around at least 10 years now. So I know what potential it has and what are the places I made mistakes, and you should not do that. So have patience, invest and remain in the market for a sizable period of time, and do not do trading.
I thank him so much for this word of advice for the young doctors. I would want to share with you the experience of having talked to my junior resident doctors today who were to pay their fee and had not paid. So I called them to my office. They all said that they had invested in mutual fund, and within a day, the market had gone down so much that they have lost. To an extent that I asked them what were those funds. They were government funds, even things like SBI mutual fund. And they've lost everything. They don't have money to pay their fee also, will have to borrow. So you've been advising mutual funds. So what is the word of caution that you would want to tell them? In one day, they have lost more than, I would say, lakhs of rupees, one day. So what is this? You must, since you're talking about it, you must have known what has happened in a day or two.
As Sari said, that is correctly right, that whenever you start investing, choose the fundamentally strong companies, right? You can say Nifty 50 stocks, which is totally a blue chip stocks. So don't be panic in the market, because market is a game of patience, right? So whenever you invest in Nifty 50 or Nifty 100 stocks, these are a good large cap companies where fundamental strong stocks are very strong, fundamental matters are very strong. So choose that company and start investing initially in the big companies, right? Not go through with the small companies. So as if you don't want to invest in direct stock, then you can choose the mutual fund. And mutual fund is the way, again, tactics to choose the mutual fund. So one is that the AUM, asset under management. You have to check in which you are investing. So you can check the AUM, कि किसमें सबसे ज़्यादा AUM है. And उसका जो fund manager का जो performance है, that is also very important. उसका क्या experience है, क्या उसकी performance है. So we can check that also to buy investing in mutual fund.
I think we are running short of time, so we'll discuss later on. Thank you very much, Anuj. Yeah, Ashish,
thank
please.
you, Mr. Anuj Gupta. Will not let you go. There is a small token of appreciation for you. I'd request Dr. K.N. Srivastav sir to please give Mr. Anuj Gupta a token of appreciation, a small memento. So we request all the chairpersons to stay back. I'm sure you'll have a lot of questions on money matters and where to invest, so we can all do that over dinner and drinks after the session. So after the money talk, now it's a very interesting talk that we have next on our agenda. As surgeons, even like common people, we are all stressed. So spirituality, healing should always be a part of our process. And who better to speak about it than Ms. Ila Tyagi? Let me read it out. She is a counseling psychologist, a therapist, and a coach with over 8 years of diverse experience. She has worked with organizations like Hopeland, Serac Education, and Pious Vision, where she mentors other aspiring psychologists. She is a certified past life regression therapist trained by Dr. Brian Weiss in the USA. Ila specializes in cognitive behavioral therapy, rational emotive behavioral therapy, graphology, mindfulness, and art therapy. She is a passionate speaker, trainer, and coach on these subjects. She has spoken a lot on this, so I'd request Ila to please come on the stage and share her thoughts. Thank you.
Good evening, everyone. I'm Ila Tyagi, and I'm truly honored to be here today to talk about something which is very close to my heart, spirituality and mental wellness. Sorry. Can you open the slide? So a little bit about myself. Over the years, since the introduction has already been made, but over the years, I have had the privilege of working with many individuals who have faced significant challenges in their lives through our work together, using rational emotive behavior therapy, cognitive therapies, neuro-linguistic programming, and other therapies also, including art therapy, signature analysis, graphology, dream analysis, and hypnosis using past life regression therapy, we have come out together out of the stress and other issues people have been facing around. People have learned not only to navigate their struggles, but to find inner peace and renewed sense of well-being. Today, we'll dive into something that affects all of us, which is stress and anxiety. We'll explore where it comes from in your profession, how it impacts you, and most importantly, practical strategies to manage it. More than that, we'll talk about why integrating spirituality and mental wellness into your daily routine isn't just helpful, it's essential. So let's talk about stress. Stress is not something new. We all have been facing stress in different ways since our childhood. This is like, stress and anxiety is like a part of our life since the youngest days, if you remember. When I go back into my days of childhood, I remember that I was diagnosed with something which I came to know quite later on in my life, that I had dyslexia and I was an audio-video visual learner. But I learned this taglines during my psychology, when I was studying psychology. So by then, when you are a kid, you do not know what is happening with you. You are not able to read properly. You are not able to understand things. And that gives the stress to an immense level, which for a child, it's very difficult to understand. And during our times, we never had these labels. We were just like, figure it out. This is how it is. Maybe you are not doing your best. You are not doing the thing which everybody else is doing.
May I ask the audience to kindly be patient?
Thank you. So, looking back, I'm sure you all would have been having siblings, or not even siblings. We always have the Sharma ji ka beta who has been compared to us during our educational ways or academic way, or in our day-to-day life. Look at them and look at you and all. Even as childhood, I was nowhere different. I come from a very educated family, and I'm the youngest sibling, and my elders sister has always been a topper. She has been a topper in everything she touches, like even in sports, she has been really good. So you can understand the kind of pressure I was having in my life. And that was not given by my family. That was not at all given by my family. But yes, somewhere the teachers or the other students, or yourself, you start feeling that, why am I not able to do it? Why am I not able to score that much marks? For various reasons, okay, fine, I had dyslexia, but sometimes some people are just not there to do the things exactly the way the society wants them to do, right? So when we come to this, we understand that what helps you the most is you have to look back, take a pause, and understand what is going on with you. So when I look back, I was having really tough time handling this stress. I was going through, you can say, I used to get fevers, and I used to always have that excuse for not going to the school. I used to always I used to feel very tired. I used to feel very feverish. I used to feel nausea most of the times. And nobody could understand what is going on with me, including my parents and my doctors. And somewhere, the things were just stuck and you were just going on, and you're just trying your best, and the pressure kept on becoming more and more on you. And somewhere you understand the sleepless night, the tension just before the exams. I know I have cried before exams because I thought that I'm going to fail, I'm not going to perform well. And luckily there was a lot of support and love from my family. They never put any pressure on me. In fact, all the pressure was on the sister since she was already doing well. So thanks to her that, some of the pressure was taken off from me. But looking back, I had already started meditating at that moment, and I think that helped me the most. I was able to pause, I was able to breathe, I was able to think what is happening, and that gave me a clarity that, the kind of stress I am taking, which is a stress maybe considered as competition with others, or maybe competition with something of a version of myself which I have created in my mind. It doesn't have to be, you just have to take a pause, breathe, and think about it, like, why am I taking so much pressure? Why am I doing all these things and, feeling all this unnecessary stress, unnecessary burden, sleepless night, all the tensions, worries, and trying to score like really good to nahi, but yeah, at least passing marks. Okay, so those were the time when I felt that, you know what, this is not the kind of life I want to live, and this is not why I was born into the world to have so much tension and stress around me. So I learned something very important is like you have to understand stress. You have to understand where is it coming from, why is it coming from, what is making this stress come, and you know why it is affecting you so much. It can be, as I said, comparison. It can be, as I said, that academic pressure, or maybe, you know, societal pressures, whatever it is. But it is very important to understand where it is coming from. So when we look back, you have to see that, you know, once this awareness is done, certain tools are very helpful, like meditation, affirmation, power of suggestions, which we'll be discussing today, so you will know what I'm talking about, are very helpful tools for you to understand what is actually going on with you and how to handle them. So let's dive into today's topic is stress in surgeons' life. So as you know that surgeons are always perceived as some superhumans, you know, like they are unshakable, they are precise, they are always on top of their games, and they are like so good, and you know, they are so stable, they are so calm, poised when they are doing their surgeries and stuff. But behind the exteriors lies the demanding reality. The emotional, mental and physical stress you endure is immense. Like, we can't even think about what you are going through. You are not just saving lives, you are making critical decisions that can shape outcomes, navigating long hours, and dealing with emotional toll of patient care, and as well as balancing your personal life. And I know it's not very easy, but you guys make it seems like easy. But the stress which you endure always have an effect. Everything has an effect, you know, when you store stress, anxiety or anything else. It comes out in different forms. It comes out in a physical way. You might feel fatigue, burnout. You might face certain health issues, like, you know, you'll have backache or leg pains because of standing long hours and all. Then you have emotional impact, which is anxiety, frustration, and sometimes emotional detachment. Professionally, you might feel impaired judgment and sometimes find it difficult to make decisions. But this raises a thought that our surgeons are a different breed of people. You have so much to balance mentally, emotionally, and physically. And the precision, expertise, and leadership required naturally bring with them a certain amount of stress or pressure. In many ways, we can always compare surgeons with goalkeepers. Success is celebrated, but one mistake can overshadow a flawless track record. Out of 100 cases, 99 may be successful, but that one miss can stick with you, leaving a mark on your career and your emotional well-being. It is the pressure, the weight of responsibility that keeps you awake at night, replaying different cases, second-guessing decisions, and feeling emotional toll of your work. I think this is something where most of the surgeons who are seniors will be, you know, connecting with, because they might have seen the ups and downs in their career graph, and they might have gone through certain stress and certain things which still might be haunting them or might be there, you know, like a scar in their heart. So many of you have found ways to cope up with the stress. There are different ways where you would have found to cope up. It can be playing music in OR, keeping things light, and, you know, having some humor around while operation. I have been in one of the operating theater when I was there, and one of the surgeon was actually having a good time talking, and, you know, I was feeling lighter when he was doing my sinus surgery. So I understand that humor was something relaxing for me when it was going through there. Then a lot of people connect with exercising, meditating, spending time with loved ones or friends around you. Yet certain scenarios bring stress to the surface. For instance, acute pain to the abdomen in an emergency, the stress of whether to proceed with surgery or manage controversially. Laparoscopic gallbladder removal, a difficult Calot's triangle leading to sudden bleeding or bowel injury. Laparoscopic hernia repair, bowel injury which can cause later complications. Scenarios like these are enough to give anyone stress or burnout at the moment, even though you are practicing all the things and trying to calm down. These things can bring stress at the moment, and sometimes you find it difficult to handle it. This is why this session is so important. This brings us to the core that this session isn't about adding more tools to an already overflowing professional kit of yours. It's about something far more important, creating a much needed pause to breathe and to find balance. In a world where productivity often takes priority over personal well-being, how often do you truly stop and ask yourself, how am I really doing? Today is an opportunity to step away from the chaos, even for a moment, to press pause, reconnect with yourself, regain clarity, because finding balance isn't luxury, it's a necessity, both for your well-being and the lives you touch every day. This session is an invitation not just to learn, but to experience a shift in perspective and experience. That brings us to the topic spirituality and mental wellness. Most of the people are aware of mental wellness as it's being a very popular topic recent days, and recent years it has picked up a lot. It's everywhere. You will find it on even social media. Celebrities are also talking about it. So sometimes I feel that mental wellness is more outshining things rather than what it is. It has become a fashion statement to talk about mental wellness. That's not the case. In reality, mental wellness is quite important to handle yourself, not just to address depression as a common phenomena, but to understand what it does and how you can work on it. So that is mental wellness for you. But not many of us are sure what is spirituality. What is it really about? What does spirituality really mean? Often the first thought comes to the mind is साधु संत नहीं बनना है मुझे हिमालयाज जाके जो मेडिटेट करना होगा मैं हिमालयाज जाके मेडिटेट कर लूंगा या कर लूंगी. Lot of times I hear this that ये मेरी उम्र नहीं है, this is not my age to go towards spirituality or go towards meditation or something like that. So spirituality, what is spirituality? Spirituality is an experience. It's a journey within. It is about understanding your purpose, finding harmony with yourself and the surroundings. It often involves introspection, mindfulness, and practices like meditation, prayer, and self-reflection. Spirituality is about alignment, connecting with something greater than yourself, while staying grounded in your own essence. It's not about withdrawing from the world. You do not have to leave your ghar sansar and go somewhere in Himalayas and meditate. That's not spirituality actually means. It actually has the very deep meaning of founding your inner peace, your inner foundation, which makes you feel centered, which helps you to have peace. And no matter whatever the external chaos is, you can still hold down to that peace and be grounded and feel better about yourself. True spirituality helps you navigate life with resilience, clarity, and a deeper sense of meaning. Meditation serves as a doorway into spirituality. It creates the mental clarity and inner calm needed to explore deeper questions of existence, connection, and purpose. However, spirituality extends beyond meditation. So a lot of people think that I meditate, so I'm a spiritual person. That's not actually it is. It is part of, you can reach spirituality through meditation, but meditation alone is not spirituality. It is a way of being, perceiving, and relating to yourself and the world in a more profound and conscious manner. So spirituality is something about way deeper when you go within. Meditation is a tool to calm yourself down and to connect with within. So they are all interconnected. Mental wellness being and spirituality is actually, mental wellness is the first step because you are more mindful about your thoughts, your actions, your words, and then you go more deeper and deeper through meditation, you bring the calmness, and spirituality is touching with the more bigger thing called universe. So where do we begin? Where should we begin this journey of spirituality and mental wellness? Anybody? Okay, so let's start by understanding power of thoughts and power of suggestions. So as you can see on the screen, you have some two iconic movies called Three Idiots and Munna Bhai MBBS. If you remember the iconic roles of them, of Dr. Asthana and Rancho, right? So Dr. Asthana, if you remember, he used to laugh whenever Munna used to do anything to trigger him. And he used to laugh, that's called laughter therapy. And that was only to make him feel little better about the situation. And of course, it was funny at the moment, but that's what the repetitive therapy is. And in Three Idiots, you would have noticed whenever Rancho used to be in something, or his friends used to be in some drift, he used to always tap his heart and say, all is well, all is well, all is well, That has been, I think, we all have picked up those things from the movies. But what does this actually mean? These kind of things means that the idea is very, very simple. Repetitive thoughts and words can shift how you feel at the moment. So when Dr. Asthana used to laugh, or Rancho used to say, all is well, all is well. At the moment they used to, repeat the words to feel good about the moment, that even the stress is too much, things will be better. Even you can laugh it out, you can make positive affirmations that, okay, everything is well around me and I do not need to panic about it, right? So to prove this, we have an experiment conducted by Dr. Emoto. He's a Japanese scientist. He conducted an experiment on water. He labeled the waters, he has kept water in different tubes. He labeled all the tubes differently. One as love, one as ugly, or something, hate, peace, something like that. So 2 good words and 2 bad words, something on those lines. So somewhere good words, somewhere bad words, love, peace, beauty, and others were hate, ugly, war. And you can see in the images, if you can see them clearly, that he kept them in the tube, and for a week he kept on saying those words to each tube. So the tube where it was written love, he used to pick that tube up and keep on saying love, 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 and used to keep it back. For 1 week he did that, and then he froze those tubes. And after that, when you put those water particles and the frozen ice into under the microscope lens, he saw that the crystals of the tubes where it was written beautiful, love, peace, thanks, gratitude, were very beautiful. As you can see on the screen, love and thanks create very beautiful crystals, and he was amazed. And on the other hand, the other water where it was written hate, ugly, war, or something else negative, never formed any crystal. In fact, they were a little bit discolored as well. So that's how powerful our thoughts and words are. Now think about this. Our body is made of 70% water. The thoughts we hold and the words we speak don't just influence us mentally and emotionally, they also impact us on a cellular level. It makes you wonder, what do you say to yourself every day? What do you say to yourself? When was the last time you appreciated yourself? When was the last time you were kind about yourself? When was the last time you felt proud about yourself? When was the last time you actually were like, okay, fine, I can do this, and you know what, I've done such a wonderful work, amazing, pat on my back. When was the last time, which is very important, you said to yourself, I love you? Every day? Lovely. Lovely. That's how it should be. I'm so proud of him that, at least he does it in the whole gang. For many of us, these acts feel silly. They are very uncomfortable to us to think about it. Of course, not for you, sir. But even I do that. I say every day to myself, looking at mirror, that I love you, Ila Tyagi. And I do give kisses also to myself. You can also try that out. It's lovely. Trust me, it works, huh? So these kind of thoughts makes us sometimes uncomfortable. Sometimes you find it very silly that, what is this talking about myself? Am I being little egoistic? It will bring ego to me. These kind of thoughts keep coming to us, and that's why we stop. So there's an ancient saying to explain this. I'll let you know. Aham Brahmasmi, which I think most of you might have heard about it. It means, and it translates roughly as I am the universe. When you say I am the universe, you affirm that the same beauty, power, and wisdom present in the universe or the cosmos also exists within you. So the question isn't whether you should love and appreciate yourself, it is why you ever stopped. You shouldn't have. Embracing the connection doesn't make you self-centered, it makes you whole, it makes you complete, it makes you centered. It reminds you that you are a part of something vast and extraordinary, that vastness is reflected in you, and that vastness is reflected through you. So when you put good thoughts in yourself, and when you talk good about yourself, when you are in immensely love with yourself, that's what you will radiate it outside also. The people around you will also feel the same way. The people around you will see you the way you see yourself. At the same time, they feel good about yourself, themselves as well. You must have noticed, like sometimes, there are people who come into the room, they walk into the room, and you are just awestruck about them. You are just like, oh my God, wow, what an aura, what a vibe, I'm so impressed by the way they talk. I'm so impressed by the way they say things or express things or explain things. Even it might be just a one sentence, but you'll be like, wah, kya bole, Baba. So these kind of things, when it comes around, how is that? Like, if I do not love myself, I will not be vibrating or sending the same energies to you. So it is so vital for you all, since you are doctors and surgeons over here, that, when you are vibrating in such things, you will be affecting it around. It will have a positive effect on your patients, on your family, anybody and everybody who touches around you. So that's something so powerful that you will understand that how powerful words and this thing. You can try it. Try it just for a week. Just for a week, and then, let me know. I'll give you my number. Send me across how you are experiencing. You can even try that with the water also. You don't have to froze the water. You have water bottle, everybody, and every day you drink water from that bottle. So carry that bottle just for 5 minutes, close your eyes, or just say it out loud. Some good things about yourself. If not, then just say love, faith, confidence, anything, whatever comes into your mind, which is positive. Just say that and drink that water throughout the day, no matter what is it. See the results after 1 week. You will see the changes in you, around you, everywhere, because it's something which spreads across you. As I said, Aham Brahmasmi. So we are the universe. Everybody else is also universe. So when you start vibrating in certain energies, you not only uplift yourself, you uplift your surrounding as well, whether it is your patients, your family, or anybody else you touch, even animals for that matter. So when we say Aham Brahmasmi, how do we start? Where do we begin? How to experience it? Now let's ground ourselves with a simple yet powerful breathwork exercise. So breath is an anchor of our existence. It's what grounds us, brings us back to the present moment, create balance when life feels overwhelming. You would have also told your patients also, right? When they are getting anxious, you will tell them, breathe, just take deep breaths, calm down. That's how breathing is. Breathing makes you calm down, breathing makes you little balanced, it makes you comfortable. You feel better when you start breathing properly. As you can see on the screen, there are certain breathing exercises which I have mentioned. You can try it on your own pace. One is box breathing, where you inhale for 4 seconds, hold for 4 seconds, exhale for 4 seconds, and hold for 4 seconds and repeat it till you feel calm and better. There are 5-finger breathing exercise which you can do anywhere. You are just tensed about it, just go breathe in, breathe out, breathe in, breathe out, works like magic. Then there are alternate nostril breathing, which most of our yoga asanas will tell you that, usually they ask you to do it in morning. Then it is belly breathing, where you have your hand on your chest and other on your belly, and you breathe through your belly. You can feel the belly growing bigger and then going down. These are some of the exercises which you can do anywhere and any time. It just hardly takes 2 minutes to 5 minutes to do that. So since I said you are going to experience it, this seminar or the speech is all about experience and shift in the perspective, we are going to experience it today. So I spoke about power of thoughts. Let's try out how our power of thoughts are going to affect us today. Are you ready? Even if you are not ready, let's do it. Let's experience it as much we can. All right. So it's called body scanning with intention breathing. I will be guiding you throughout the process. I will tell you certain words of positivity, but if you think you have anything which you want to put in your body or in your consciousness, you are free to use that. I will just guide you with the certain words which I feel and I feel connected, which is magical. So with that, kindly close your eyes, all of you. Take a deep breath in. And slowly breathe out. Now imagine a wave of relaxation flowing on the top of your head to your toes. As the wave goes down from the top of your body to the tip of your toe, feel all your body parts. What are you feeling around each and every body part from your head to toe? If you are feeling uncomfortable or feeling any pain, whichever place you are feeling that, Give a thought that instead of pain, it is filled with love, it is filled with peace, it is filled with calmness, or any other word which you can relate to. Scan your body from top of your head to the toe and keep breathing. Keep sending positive vibes throughout. Love, faith, confidence, peace, harmony. With each breath you take, you are releasing all the tension and relaxing yourself more and more, giving good thoughts about yourself, saying I love you to yourself. As you breathe in and breathe out, feel the pain or discomfort being replaced by love. You are filled with love, positivity, calmness. As you breathe in and breathe out, and filled with love and positivity, gently open your eyes and take a moment. How did you feel? You might even write down this experience. It helps you to track your progress and deepen your self-awareness. This is a very, very lovely technique. You can do it anytime you are feeling anxious, you are feeling pain in your body or any discomfort. It can be even worked on the diseases which you must be having. Just try to send some positive thought into it. Now, since we have grounded ourselves, that's like the first step of our experiences. Let's move to meditation, the next step of our experience. So there are different kind of meditations. There is mantra meditations where you just chant something out loud, something good like Om, peace, or just hum. You know, like if you know that humming, when you hum around, you will not have any thoughts. Try it out someday. When you hum, you will not have any thoughts. So when you are stressed, start humming around any song, any music you have heard, and you will see that your thoughts are slowly disappearing and you are getting more calmer and peaceful about it. Then there are guided meditations where you listen to a guided flow like we did on the breathing. You will be guided along. They usually take through your series of steps and help you relax and focus. That you can do at night and whenever you have time. So there are a lot of, if you are new to it, you can use some apps to help you out, like Heartfulness is something which I personally use. And I can tell you that this is something very best, something really amazing, because it has daily affirmations, it has daily exercises, you can write down, you can journal it over here in this app. You can do a lot of activities which they come out for the week, which helps you to grow in your personal life and to help you maintain the calm and peace. So if you want, you can check out. This is my favorite. There are many apps, but I can only tell what I have tried, right? So now let's experience a powerful heart meditation. Now we have grounded ourselves, we have become calmer, we have understood the power of thoughts. The second is also power of thought, and this is where you will be understanding when I say Aham Brahmasmi, I am the universe. So how do I connect with my universe and how do I become one with universe? So shall we begin? Yeah? All right. Slowly close your eyes. Take a deep breath in. And slowly breathe out. Feel the divine healing energies enter your body through your feet. Relaxing your feet. Relaxing all the muscles, tissues, and cells. Slowly moving towards your legs. Relaxing your legs. Releasing all the tensions, all the pain you have been carrying around. Slowly moving towards your knees, your thighs, your hips, your pelvic, releasing all the tensions, all the tightness, relaxing you throughout, making you feel lighter and lighter. Slowly moving towards your abdomen, your lower back, releasing all the tensions, all the worries. Releasing all the tensions, all the worries, and relaxing yourself. Slowly moving towards your chest, your upper back. Slowly moving towards your shoulders, your arms, hands, palms, fingertips. Releasing all the tensions and worries, all the burden you have been carrying around. Slowly moving towards your neck, the back of your head, top of your head. Slowly moving towards your forehead, eyes, nose, your cheeks, your chin, your jawline. Slowly moving towards your ears and relaxing you completely from within. Now bring your attention towards the center of your chest and give a thought that the divine light, the divine universe is within me and I am moving towards it slowly. If you are having any thoughts or you are feeling drifted apart, bring back your attention to the center of your chest and again give a thought that there is divine light, the universe within me, and I am moving towards it. As you are in this divine state, feeling relaxed, peaceful, happy and content, you are being connected with the universe. You are becoming one with the universe. Now you can slowly bring your attention back to your body and open your eyes when you feel comfortable. Take a moment to feel and understand what did you feel during the session. You can write down your experiences for better understanding. If you practice it daily, you can see changes in yourself and around you. And if you journal it, it will help you to understand where you were and where you are now. With this, I will conclude today's session, and I want to emphasize that this isn't just about tools and techniques. It's about recognizing that we are all on a unique journey, filled with challenges and beauty alike. By integrating mental wellness and spirituality into your daily life, you are not only enhancing your capacity as surgeon, but also deepening your connection with yourself. Because when you heal, you don't just transform your own life, you create a ripple effect of healing of those around you. You can only pour into others when your own cup is full. When you nurture your well-being, you show up stronger, not just for yourself, but also for those who rely on you. Thank you all for allowing me to share this space with you. I hope you leave here feeling inspired, supported, and ready to enhance and embrace this change in you. Thank you so much.
Thank you, Ela. Thank you so much. I think it was an important lecture for all.
Thank you.
First of all, I must say that you are a brave lady to accept the fact that you had dyslexia in childhood and that you coped up with it. Second thing I want to say is, to see you reading so fluently from the papers, I refuse to believe that you were a dyslexic.
You have no idea how many times I have. I think my sister is here. You can ask her. She can write a book on my dyslexia.
I do believe you, yeah. I know it. I have worked hard on dyslexia. I also want to bring to your notice that surgery is a profession recommended for dyslexics. You must have read the professions. There are certain professions that are recommended for dyslexics. They have an extra sense. And so surgery is a recommended profession, and I'm sure amongst us there must be many who were dyslexics in childhood and have a poor handwriting, right? And maybe I would just want to summarize the take-home messages.
Yes, please.
It may not be just spirituality and meditation that would get them all out of all difficult times. So probably we need to have people who know the serenity prayer, would know that you have to have the serenity to accept the things that you cannot change, the courage to change the things that you can, and the wisdom to know the difference between the two. I think it is one of the most important prayers for all of us to work on. And like you said, there is no magic that can happen over that point of time where there is stress, but we need to work on it, and it's an ongoing process. Thank you so much for a lovely session.
Well, Ela, that was an awesome talk, and will not let you go. I'd request Dr. Ratna Chopra ma'am to please give Ela Tyagi a memento, a token of appreciation, please. Well, aren't we all thrilled at this beautiful session? Thank you so much. I'd request the chairpersons to please stay back for the next session. Tanushri.
Thank you so much, ma'am. I think all of us are pretty rejuvenated by your talk, and I think pumped up to now go to another academic session. So that is on esophageal potpourri, and our first talk would be by Dr. Praveen Bhatia. Sir is the director of Bhatia Global Hospital and Endosurgery Institute, and he's the ex-chairman, Institute of Minimal Access, Metabolic and Bariatric Surgery at Sir Gangaram Hospital. Thank you, sir.
You have heard him in the previous session also, and Praveen is one who can speak and who can, mesmerize the audience. So the topic which he has to speak is that what not to do in lab fundoplication. Dr. Praveen Bhatia.
Can we have the lights off?
May I invite Dr. Vinod Malik sir to be on the dais, please, as a chairperson. Thank you.
There's a cherry sachet. Thank you.
Thank you very much. Again, we are coming to the ground. And the topic which has been given to me by Dr. Ashish Dey is what not to do in laparoscopic fundoplication. And all of us have been listening to Dr. Anil Arora and different surgeons from all over the city. And most important message which I want to convey, especially to my younger colleagues, is that if you listen to patients carefully enough, they will tell you the diagnosis. I think most important is listening. And as we listen to the patients, and whether it is reflux, whether it is dysphagia, then only we start making the diagnosis. And then most of us have been taught in our Thank you. It is all about finding the calm in the chaos. So I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. I am not going to bore you with the stats of these complications of anti-reflux surgery, but to my mind, most important thing is that if you want to be successful in laparoscopic fundoplication, as we discussed, proper patient selection, meticulous surgical technique, attention to details. God lies in details, devil also lies in details, and close post-operative follow-up. That is very, very important. Most important is, as we mentioned in the morning or in the earlier hours also, that most of us may do more harm by doing the laparoscopic Nissen fundoplication in a patient who has not earned the surgery. So patient has to earn the surgery, and one should always make sure that we confirm whether the patient is having GERD or not. And if unnecessary surgery has been done, the patients will again have dysphagia, again have reflux, and then the challenges can be there. And I am not going again into the details of it, that investigating the patient thoroughly is of paramount importance, be it 24-hour pH manometry, esophageal manometry, to rule out whether the pressure is there or not. We may tighten the sphincter and later on the patient may suffer dysphagia, and whether we should definitely go in for endoscopy. And as we discussed, I at least strongly believe on doing the barium swallow in every case, and the CT scan, CT gastrographin also, so that we know the GPS. In what direction are we going in? Then we'll reach faster. Today, if we do not have the GPS, and if we start asking A, B, C, D, we may reach to the destination, but it will be delayed. Most important is that if, for example, we find that there is a complex motility problem, then we should not offer a 360-degree wrap. It should be either the toupee or the door. But again, if more important, the message which I am going to convey today is there is a pill available for the reflux, but there is none for the obstruction. If that message I am able to convey, my job is done. So a patient may suffer later on with severe dysphagia, and so one should definitely be careful that we do believe on manometry studies. And for example, this patient, just a case study, that she had dysphagia after surgery, and 60 years old female, she had presented with dysphagia and reflux, and pre-operative manometry was not done. And again, one liner for this is, every criminal has his own justifications. Every criminal has his own justification. Means we would always say, no, in my hospital, manometry is not being done. In my hospital, pH metry is not being done. I think that is not the answer today. It is being done. You can refer the patient at a place so that ultimately we have the complete pre-operative diagnosis and then we go in. And this kind of patient, if you operate, then in this post-op period, again, she has the severe dysphagia and she required is endoscopic dilatation later on. So again, the manometry was done and it was found out that she was suffering from motility disorder. So one should be very, very careful. Again, when we are mobilizing, if we do not see the inferior phrenic vein, we do not go up to the mediastinum to mobilize the esophagus, that means we are not doing the justice. Again, we should never ever leave a large hiatus. We have had occasion, we have seen in our lifetime also many slipped rafts into the thorax and the patient has been operated next very day after the slipped wrap. So one should be very, very careful that we are not leaving a large hiatus behind. And when we are putting in the suture, as we had discussed also, I believe, strongly believe, you cannot manage what you cannot measure. So we always put in a bougie, we see that it is not a tight wrap or not a tight crural fixing, and then only we are satisfied that the patient is not going to have the dysphagia later on. Many times when, for example, all of us have been taught right from our PG days that it should be a shoe shine maneuver. But again, I will show you a small video clipping later on that when we are doing the shoe shine maneuver, it has to be thoroughly seen from inside our mind that it is a shoe shine maneuver rather than a twisted shoe shine. Means if you have not dissected all around and if you are making a twist in the fundus, if you have not mobilized the short gastric vessels, then again it will be a twisted kind of wrap and that will appear that you are doing a shoe shine maneuver, but it will not be sufficient and the patient will have more dysphagia after the surgery rather than before. And again we emphasize on good posterior fundus dissection. We always say fun lies with the fundus. So whether we are doing sleeve gastrectomy, whether we are doing the hiatus hernia, fundoplication, so we should always make sure that the fundus has been lifted up anteriorly and it has been freed from the short gastric vessels, and then we start rotating, and that will definitely help us. And if we do not, there was a question about the short esophagus. If we do not dissect the esophagus up to the inferior phrenic vein into the mediastinum, or if we do not dissect the posterior part of the fundus, and we may think that we are doing it is a short esophagus. No, it is a mistake. So one should always make sure that we are dissecting it. Again, we have a habit of measuring with the umbilical tape. We take 8 centimeters of umbilical tape, 5 centimeters above, 3 centimeters below, so that ultimately we know that dissection has been complete. And when we are making sure that approximately 3 to 4 centimeters of the esophagus is seen intra-abdominally, then only we are satisfied. Many times I have seen surgeons in workshops also that they do not do the posterior dissection well, because of the apprehension in the mind about the aortic injury or any other important structure injury that ultimately compromises the length of the esophagus, and that gives rise to one, the dysphagia, two, the hernial, the wrap, migration or the recurrence. And make sure when we are doing the wrap, when we are closing the fundofundic or gastrogastric sutures, approximately 3 centimeters, 2 to 3 centimeters of the esophagus has to be inside the abdomen. Now you see this. This is I am thankful to the surgeon, I will not name him, but the dissection has been done and the esophagus is being mobilized. But could you see the longitudinal fibers of the esophagus had given way? And at that stage, the surgeon realized that what has he done? And then he ended up by doing a Dawes fundoplication rather than a Toupet fundoplication or a Nissen fundoplication. And when we are having a large hiatus, then aim is that we should put maybe 3 sutures, U-shaped or horizontal mattress or vertical mattress, it all depends, but it should be with non-absorbable suture. And if we are able to close it, and honestly, we do not believe on anterior suturing, the Edson suture. We strongly believe on posterior crurorrhaphy so that we are not making it tight. But if, for example, the hiatal defect is more than 4 centimeter, we are not going to place in, we are placing the sutures, but we are going to place in a mesh also, so that again the recurrence is not there, the wrap migration is not there, so one should be careful. And we are taking the polyester sutures for number 2, number 2, because diaphragm is an excellent contractile muscle, and that can break even, and that can lead on to recurrence later on. So one should be very, very careful about that. Again, as you know that I am fond of stories, and I will tell you a Dal Magne story. Dal Magne story, can you imagine that he has been the pioneer of doing laparoscopic Nissen fundoplication. He was doing a lot of surgeries in Belgium, and he had published so much about the tips and tricks of doing the laparoscopic Nissen fundoplication. When he retired, when he shifted himself to Paris, then he realized that now his wraps are slipping up into the thorax. And he was surprised also, but he thought that I have been professing the laparoscopic Nissen fundoplication for ages now. Why is it, how is it that now I am seeing the wraps which I had never seen in my life? Again, God lies in details, devil lies in details. He started working backwards, and he realized, can you point out what was the problem? Anyone, any learned surgeon? What problem did he find? Inadequate mobilization. He has been mobilizing esophagus from 92 onwards. Next. Suture material, he was using non-absorbable suture material, and which he continued in Paris also. Next. He was doing the cruropaxy every time. What I mean to say, he was the master, he has described, all of us have seen the videos also, but he was not following the patient. No, it is wrong. He was following his patient wonderfully, but can you imagine, going into the details, in Belgium, they were extubating the patient on the table. Whereas in Paris, they had a habit of shifting the patient to recovery room, and when the patient started retching, then they used to take the tube out. And that was the time when the hernial wrap migration was there. So what a great lesson to learn from this, that please make sure you and anesthetist are a part of a team, and anesthetist should be told that the patient should not retch, maybe give Decadron, maybe give Emisat or whatsoever, but patient should not have a retching immediately post-op, then it can lead on to challenge of wrap migration. And if we are doing the wrap too tight, then again the patient will have the dysphagia and gastric bloat, gas bloat syndrome. So make sure, ideally, what is the size of our bougie, which we use in GCT, in sleeve gastrectomy, is 38 French. But the recommendation is one should have a bougie of Meloni bougie, for example, 50 to 60 French. That means we should give a concession of that we should not make the tight crural opening, and then patient will have dysphagia. And again, one piece of caution I would love to pass on to my especially my younger colleagues is, when we have mobilized the fundus, when we are placing the fundus behind the esophagus, it should be behind the esophagus. It should not be retrogastric. It has to be retroesophageal rather than retrogastric. Then only it will be there. And we were discussing about the bougie video story. Can you imagine? This is a large defect. And in this, I was doing this surgery because it was a large defect, and I requested my anesthetist, could you see that? The bougie has come out. Now what next? How will you manage that? Anyone? Anyone? Suture. But again, a piece of caution is, it is all about finding the calm in the chaos. You request the anesthetist not to pull out the bougie immediately. If he does immediately, then you will not be able to find out the posterior rent in the esophagus. So gradually one should withdraw, one should take the suture in, one should put the suture and then withdraw, so that ultimately we are sure that we have closed. And now the mesh had already been placed. So what shall be there in your mind? You have already placed in a mesh, you have already closed the crura, and that was the last check that we had done it. So what next? Absolutely. So I left the mesh behind. This was a crura patch which we were discussing, but I added, to be on the safe, if there is a safety and more safety, I added feeding gynostomy in this patient. So that I fed the patient with feeding gynostomy for a few days, and once the patient had healed well, and then I could start with gastrographin and no leak, and then the patient did very well. So again and again, safar mein nikle ho, dhoop to hogi. Once you start operating on these kind of patients, there will be some challenges someday or the other, but one should know how to manage those complications or challenges. And again, I am saying that please make sure that when we are doing the shoe shine maneuver, we are not taking one anterior part of the stomach on one side and posterior on the other side. It has to be the posterior fundus which has to be held by both the hands. We can place in a suture, shoe shine the maneuver, retroesophageal rather than retrogastric, and then only we will be able to do the justice. And key or secret to that kind of shoe shine maneuver is that we should always mobilize the posterior part of the fundus. Most of us separate it from the spleen, but when we should always make sure that the apex of the crura also have to be shown or seen, so that we are making an adequate dissection in the posterior aspect, and then only we'll be able to do it. Again, coming to the post-op, 2 more slides. Post-op mistakes, we should never ever overlook immediate post-operative dysphagia. Many times, most of us start thinking surgery, yes, some dysphagia will be there and later on it will improve, but there will be many situations that one has to investigate thoroughly, rule it out that you have not made a tightened wrap or a tight crura, and if the need is, then one may go in and send the patient to Dr. Aniroda for dilatation, but again, find out the cause. And do not assume that recurrence is equal to failure of fundoplication. Means that please never ever jump to the redo surgeries. Many times, many of us have a habit of redoing the surgery, and that can later on cause lot of challenges, and patient can have maybe psychic problem also, and that can lead on to definite challenge. So one should always investigate, and one should have a high threshold of going in for redo surgeries also. And yes, gas bloat will occur in the post-op period for some time, but it usually settles down. There are 2 schools of thoughts. There are people who do not mobilize the short gastric vessels. There are people who will always mobilize the short gastric vessels, which we do in a limited manner, so that the gas bloat is there, but ultimately it settles down. And again, please do not do the unnecessary surgeries in the patient. Yeah, this is a last video clipping which I am just showing. That can you imagine? The surgeon I am thankful to the surgeon who has shared this video with me, and he is mobilizing for placing in a mesh. He has mobilized the left part of the liver also, and gone into such a depth that he is working close to the heart. Obviously, he should not put in attack here, but he had a bleeding from the vessel, and it carried on, and ultimately it could be stopped with suturing, with lot of patience, that the patient could be stopped. And I am not going to show you this video, but again, my message is loud and clear. There is a pill available for reflux. There is none for obstruction. Thank you very much. Thanks a lot for your kind attention.
Thank you, Dr. Bhatia, for a very impactful lecture.
Thank you.
I just want to ask you a couple of things before the audience asks you something more. How long you would like to follow up these patients, when you would finally discharge these patients from follow-up, and with the expectation that he will not deteriorate?
Very good. Answer is, when the patient is admitted for surgery, next day we always go in for gastrographin We want to be sure that there is no leak and the wrap has not migrated up, and then we start with liquids. And after 48 hours, because no drain had been placed, the patient goes home. After 7 days, the patient comes for follow-up, and most of the times they have switched over from liquid to semi-solid to solid diets. And we carry on telling them, yes, if you have any challenges, please report, but gas bloat is known, slight dysphagia is known. If it worsens, please come up. But I will not be in a position to tell you that after 6 months they are free to move around. No, but usually most of the times these patients carry on improving maybe 3 weeks or 4 weeks, and they are taking as normal diet as they were taking before.
So after 6 months, if the patient is fine, you would discharge this patient from follow-up and he can come on if he has some symptoms or something like that?
No, I would not say discharge the patient from follow-up.
Discharge
They will be, the patient will be on a long-term follow-up, should be on a long-term follow-up, but we always tell them that these are the challenges. If you face them, please report back to us rather than going for another surgery.
I have one a very significant observation. When I was in California with Jeffrey Peters, he would be giving a lot of importance to the celiac branch of vagus nerve. Here I have seen many people do this operation, fundoplication, but I don't think people are really looking for the vagi, or they are even trying to preserve this branch of celiac branch. So what's your take on that?
My answer is that we try our best to save the hepatic branch of the vagus as much as possible. We do not want to make a patient to have gallstones later on. If I sever the hepatic branch of the vagus, which is going into the gallbladder, then the patient may develop stasis and patient may develop the gallstones. So we definitely want to prevent any injury to the vagus, preserve the vagus, and if we are able, and most of the times I would say that we are able to do the Nissen fundoplication very well, just taking care that we are preserving the branch to the vagus.
And an observation, that is that, it's not a very difficult operation to do. Who should be doing it? What should be his volume to be able to give good results to the patient?
Who should be doing it? The surgeon who has done good number of laparoscopic cholecystectomies, appendicectomies, hernias, and so on and so forth, and who has had a good exposure of that area. I think that is most important. Most of the people will do the incomplete job, incomplete mobilization, incomplete suture fixation, because they have not been to that area quite often. Thanks to Arun, thanks to us, thanks to 92, 93 onwards batch who had done so many lap choles, and after that we had so many bariatric surgeries that now we are so confident in working in that area, going into the mediastinum, going up to the inferior phrenic vein, that we are able to do it.
You should have an interest in this area, know this area very well, and should have a volume of this.
Absolutely. Know thy enemy well.
Thank you, Praveen, for a very lucid presentation.
Thank you.
I think we can go for the second speaker.
Sure.
Is
Thanks.
Dr. Deborshi here? Yeah, now this second speaker is Dr. Deborshi Sharma, and he'll be speaking on Barrett's esophagus, when to operate. Dr. Deborshi is Professor of Surgery at Ramana Loya Hospital and at the unit, and a very distinguished surgeon, Secretary of AMASI, and so many posts he's holding. He's also GC member of ASI. Deborshi, please.
Thank you, sir. Thank you for your kind words. It's always difficult to speak after such an opulent and majestic speaker. I hope to carry on a little bit whatever I can. Right. Barrett's, with permission of the chairman, sir. Barrett's, when to operate. That is something which Ashish asked me to speak on. It's more of an endoscopic disease which the gastroenterologists treat. But we do come across with the prevalence of GERD and other refluxes, which we see both the acidic and the alkalines. Just to name what exactly Barrett's is a change in the normal stratified squamous epithelium beyond the squamocolumnar junction due to the reflux which happens, and you have a metaplastic columnar epithelium there with the goblet cells. The problem with Barrett's is that it is ever increasing, and it is claimed to be seen in 1 to 2% of the individuals all around. And with GERD, it is associated with around 15% of the patients. What exactly happens is that with reflux, the squamous columnar junction goes up proximally in the esophagus, and due to the reflux, in a normal stomach it doesn't happen, but when you have a reflux this happens, and there is a change in the epithelial lining. And when it goes proximal beyond 1 centimeter of the squamous columnar junction, beyond the G junction, and the intestinal biopsies have and the endoscopic biopsies have intestinal metaplasia, we call it a Barrett's. Now, who are at risk? If I am to say that almost 90% of the people who are sitting in this hall today are at risk to these kind of things like GERD and next into Barrett's. It's people, I'm not talking about the age, all of us are young here, but with age, male sex, smoking is a big risk factor, central obesity, Caucasians are another risk factors, it's very common in the European countries, and patients with high degree, first degree relatives of patients who have had a carcinoma esophagus, these patients are also at risk. Now, what exactly is the problem with Barrett's? The problem with Barrett's is that, one, it is increasing in incidence, and the next thing is it is associated with esophageal malignancies. This is the problem at hand. But associated problems with that is that it is not only we have malignancy, we cannot predict malignancies in many patients. We cannot say that low dysplasia is going to go into high dysplasias and ultimately into invasive cancers. Then there is an issue with sampling. The pathologists, there are a lot of sampling errors taking endoscopic biopsies. There are different rules of taking to do a biopsy in a Barrett's. To take a sample, then there are many steps at which there can be errors. So coming to this, the rule is that in 2 centimeters, if you have a 2 centimeter Barrett's, you should take around four samples of the Barrett's and eat one in each quadrant. And if this lesion is less than 2 centimeters, the biopsy should be increased on that. With that comes the Prague classifications and the Seattle protocol. The Prague classifications tells you about the 2 things. One is the circumferential involvement of the lower esophagus and the extent to which it has been involved. As it comes towards the esophagus, the initial part, there can be a circumferential involvement. That involvement is measured as C, and the M is up till which the maximum distance to which it is involved from the squamous columnar junction. And added to it is the Seattle protocol of taking a biopsy. Take it at the 4 quadrants, that is the rule. Take it at the dependent position first. Take it at the distal part first, then come proximally. So this is how take four samples at 2 centimeters and come proximally. So ultimately you get this kind of a picture of a negative dysplasia, indefinite ones, the low-grade dysplasias, and ultimately to the invasive cancers. As because it's a progressive disease, surveillance is very important in this disease, because if you can detect them early, endoscopy is something which is very helpful. By endoscopic, we'll hear it from Dr. Anil Arora, how endoscopic treatment of a Barrett's can be done. And this surveillance, how frequently you have to do that surveillance depends on what is the length of the Barrett's. If it is less than 3 centimeter, you do it less frequently. If it is more than 3 centimeter, you'll have to do it every 3 years. Now, coming to the surgery part of Barrett's, including endoscopy as a part of surgery, endoscopy has been a mainstay to eliminate dysplastic and the metaplastic epithelium, and it helps in greatly reducing the incidence of cancer. The first endoscopic procedure which comes is the radiofrequency ablation, which is very effective in patients with low-grade dysplasias. It has got a very high efficacy rate with a low complication rate. The complication rates of perforation, stricture, post-operative post-endoscopy strictures are very less with that. It has almost taken over argon plasma coagulation and photodynamic therapies. So RFA is better. The next 2 new kids in the block are the endoscopic mucosal resections and endoscopic submucosal dissections. So mucosal resections are the smaller ones and the submucosal dissections are the bigger one, means you tend to dissect a lot of tissue there. So definitely the complications of EMR is lesser compared to ESDs, but still ESDs are helpful in some specific cases. Now coming on to the surgical part, whether we have heard a lot of nisans today, how good will be a nisans in a patient with a low dysplasia? The literature very clearly says that there is no definitive benefit of doing a nisans on a patient with a low dysplasia not to go into a high dysplasia. It is not superior to a PPI therapy. So doing an anti-reflux surgery doesn't help. But if you ask me, I always do a nisans in a patient with low dysplasia also. Something for the surgeons is that in a group of patients where the endoscopist has done a mucosal resection or some kind of an endoscopic therapy, in those patients, to prevent recurrence, if you do a nisans in this group of patients, there is a less chance of them going or recurring or going into malignancies. This segment of this section of patients which have got a long segment Barrett's and associated with a hiatal hernia which is of more than 3 centimeter, in these patients, if you go ahead and do a nisans after an endoscopic therapy, this patient's health. So that is the only group of patients where a nisans of fundoplication can help. Beyond that, the other procedure is an esophagectomy, which you can do. This is definitely indicated for a patient with an advanced neoplasia or invasive disease. And in patients of T1A disease also, where you have a differentiated tumor, where you have a lymphovascular invasion, where ablation is technically difficult or you do not have a person who can do it or it has failed, those are the patients where you go ahead with an endoscopy, esophagectomy. Summarizing for the day, ladies and gentlemen, surveillance is something which is very important in Barrett's. Barrett's, a modification of lifestyle, some medication definitely helps. The problem is that we cannot predict the progression of the disease at times. Surgery or endoscopy, our procedures always should be done when there is an anatomical defect, when there is a definite hiatal hernia. Low-grade dysplasias do require a strict follow-up, but many of us among us will do an nisans and then follow these patients up. High-grade dysplasias always require an endoscopic procedure if available, but an invasive malignancies requires an esophagectomy. Thank you. Thank you very much.
Thank you so much, Dr. Devarushi. I'll share my ignorance with you. I was thinking of submucosal resection. Maybe there's going to be a talk after this. How much circumferential involvement will call for submucosal resection?
Tell you better.
And do you do a complete circumferential resection or only
the chances of strictures and all these things will definitely submucosal resection.
And then after you excise the mucosa, would it be healing by fibrosis or mucosalization will happen?
The mucosa do regrowths, do grow back.
So if mucosa is going to regrow back, it is going to be subjected to the action of acid again. The duration, how much duration, you must have studied about it. How much time does it take for Barrett's to develop again after mucosal resection?
I'll tell you that. That is what we say, all these patients are prone to recurrences. This is the group, if you do a nissan fundoplication on them, following that, the reflux is less. It is very difficult to say in which patient is this going to regrow, at how fast it is going to grow. Even if the patient has a low-grade dysplasia, it is very difficult to say who is going to go into a high-grade dysplasia in how much of time. So the rule is that if you have a less than 3 centimeter kind of a Barrett's, the surveillance protocol, you do a surveillance more than 3 years later, or maybe some books do write it as 5 years also. But if it has more than 3 centimeter, you do the surveillance more frequently. So these patients also similarly, depending on the risk, depending on the size, you do the surveillance post-op.
Another question that is very baffling is how frequently must you biopsy Barrett's?
When you do that, repeat endoscopy, that is the time you do the
So every time you repeat an endoscopy, you must biopsy?
You do a biopsy. You do a biopsy. the biopsy should always be one in one quadrant. There are 4 quadrants. Should be one. You should do the dependent one first, because if you do at the top, the blood is going to come down and obscure it. So do the dependent one and the furthest one first. Then you slowly come. Every 2 centimeter, you do 4 biopsies, four tissue, and then you come. If there are 8 centimeters into 4 into 4, it will be 16 samples which will go on.
Number of samples is fine. What I meant was, supposing you repeat an endoscopy after 6 months and you find...
You don't do it after 6 months.
You don't do it. So what is the frequency at which...
That is after 3 years. In the surveillance time, that is what I am trying to say.
Thank you so much.
Thank you. Thank you very much.
So we invite the next speaker, Dr. Anil Arora. Dr. Anil Arora, you must be aware, I think she will be introducing him. Please do.
Yes, sir, definitely. But before that, I would request Dr. Vinod Malik, sir, to please give a memento to Deborshi, sir. Yes, and for the next speaker, I think not just me, all of us know him. Dr. Anil Arora, sir, he is the chairman of the Institute of Liver, Gastroenterology and Pancreatico-Biliary Sciences at Sir Gangaram Hospital. So glad to have you here for throughout the conference, and so over to you. Thank you.
Good evening to you all. At the outset, I am extremely thankful to Professor Malik, Ashish and Tanushri for giving me this opportunity. I think till Ashish entered, I thought I was a lone warrior gastroenterologist amongst the auspicious day of spirituality, money matters and the surgeon's dominance in the meeting. But first of all, I must congratulate Dr. Malik and Ashish for bringing this topic of esophagus, which is something which is frequently ignored both in surgical as well as gastroenterology conference. This is the portal of entry of almost everything into the GI tract, and somehow it has always been pushed to the background when you have fancier things like malignancies and pancreatitis which come into the forefront. I thought Dr. Ila's talk may not have gone well down across the board, but looking at the energy which I think Praveen Bhatia absorbed from almost all of us, the way he has come up with 5 non-doers in patients with surgery in fundoplication. If today I was to be the surgeon, I will not stick to those 5 days and this. You will be surprised to know that we are together for almost half a century together. And the type of energy, I think he must be practicing what Ila told us to today. So we'll go back and start doing the same thing. So coming to my topic of endoscopic treatment of reflux, when, how and for whom. We know PPI, as Dr. Praveen has been repeatedly insisting and trying to tell us that there is some treatment for reflux, that is a pill. All of us know the conundrum of PPIs and the new kid on the block called PCABs, or potassium channel acid blockers. These are the wonder drugs which will totally neutralize the acidity. And then we have the brilliant surgeons which do a wonderful job of laparoscopic surgery in patients who require surgical intervention. So where do we come in as endoscopists? Where do we fit in as endoscopists to come and do the therapy for reflux esophagitis? Now basically reflux primarily occurs for 2 reasons. That you have a low pressure at the lower esophageal sphincter and there is something wrong with the crura of the diaphragm which leads to the laxation. So 2 important factors for the reflux are lower esophageal sphincter and the problem with crura of the diaphragm. So what is reflux? Reflux by default is a subjective feeling. Anybody who has a heartburn, I'm not talking of young couples getting heartburn because of different reasons, but a medical heartburn means only one thing. In fact, there is no differential diagnosis in medical science. Heartburn in medical terminology would only mean one thing. But so far as we are concerned as clinician, we have to have objective proof of what is reflux. What is that objective proof? Either you have to show there is a definitive mucosal injury on endoscopy by showing erosions at the lower end of the esophagus, or else in case there are no erosions, you better bank upon the objective modality of documenting the acid exposure by doing an esophageal manometry and esophageal recording. So these are the various types of degree of the reflux, stretching from grade A to B to C to D, depending upon what is the extent of the injury. So this is a classification given in the by Los Angeles group, Lyon's classification, which everyone of us has to follow. And whenever we tend to do procedure and endoscopy to document, we try to classify the laxness of the lower end esophageal sphincter or the degree of weakness of the crura diaphragm by retroflexing the scope and trying to see what is the distance between the scope and the crura of the diaphragm. Depending upon the difference between the scope, if you conventionally we have a diameter of the scope which is to the tune of about 13 millimeter. So if the area between the crura of the diaphragm and the scope can permit one more scope, that is Hills 1. If it permits two more scopes, then that is Hills 2. And finally, a lax wall with a proper visualization of squamous columnar junction means Hills grade 4. That is a degree of hiatus hernia. Now, if any patient who has a grade 3 or grade 4 Hills, that is a surgeon's baby, we as an endoscopist will never like to interfere and hand over the patients to the surgeons for therapy. Why does reflux occur? I think it is very important to understand that two important mechanisms are that even in normal physiological, I think we need to charge the battery. Even if we tend to have reflux, part of the system will try to push the upcoming food down back into the stomach because of the peristalsis. Only when you have a poor esophageal clearance would you tend to develop a reflux esophagitis. And a combination of the poor esophageal clearance coupled with relaxed LES is what gives you gastroesophageal reflux disease. Something which has never been talked about in any of these meetings, something which is so crucial to development of reflux esophagitis is called TLSER. Dr. Prabal did talk of this entity. This is called transient lower esophageal relaxation. In fact, majority of the patient with reflux do not have hiatus hernia. And in this subgroup of the patient, 90% of the time, reflux occurs because of the transient relaxation of the lower esophageal sphincter. Nobody knows about this entity, nobody has taken it forward, and if we are able to tackle this entity medically or surgically, I think we'll be doing a yeoman's job. This is something which is frequently underreported, very least understood entity, and this is the commonest cause of reflux today in the absence of a hiatus hernia. This is called transient relaxation of the lower esophageal sphincter. Once you have hiatus hernia, everybody knows, depending upon the type of the hiatus hernia, you may see reflux degree. And once you have gastroesophageal reflux disease, everybody is aware of the fact that you have to change lifestyle, you have to use a combination of the drugs which will suppress the acidity, you have most of the drugs which are coming into the market. Parveen would remember that, I'm sure most of you would remember. The first drug which came into the market for suppression of acidity was a drug called cimetidine, which was imported from abroad. And then this was the first H2 receptor antagonist. And then in 1982, when we were appearing for our MBBS final exam, this new drug called omeprazole came in as a big bang. But then there was a report that this drug is known to cause neuroendocrine tumors or gastrinomas in the rats, so it was withdrawn. It was only in 1989 that it was established that particular side effects of proton pump inhibitors in causing gastrinomas was a species-specific effect. It will produce gastrinoma only in the rat. Not even a single report has been established in the human beings. And hence, drug came into the market and they gradually climbed up to the chart of the best-selling drugs in the world by 1980. And over the last 2 years, now these proton pumpers are being replaced by new sets of drugs called PCABs or potassium channel acid blockers, something like vonoprazan, which is coming into the market. But in spite of whatever is available, 40% of the time, with suppression of the acidity, you may still have incomplete relief of the acidity. So the current limitations of the therapies are how long will you continue? Nobody knows. What are the side effects of therapy? I'm sure you would have read recently in Lancet and other articles that long-term of PPI use has been associated with nephritis, osteopenias, and increased GI tract infection. This has been the burning topic recently. And I'm sure you would have also recently seen that drug like Zintac, which is a classical H2 receptor antagonist, which was supposed to be so safe that this was the drug of choice even in a pregnant women with reflux, has been withdrawn from the market because of the risk of malignancy. And finally, there are 30% of the patients who, in spite of complete suppression of the acidity, will continue to have refractory GERD. And this is the time when, if you have a volume reflux, if you have a huge amount of bile which comes into the esophagus, if you have a large hiatus hernia, what would a drug which is trying to suppress the acidity do? And hence this concept of response of only 60 to 70% with PPIs or PCAPs. And I do not know what is the practice in surgical aspect, at least Ashish is there. 95% of our patients who come to us as gastroenterologists, they are not ready for surgery. They'll go all out for lifestyle measures, they'll look for any drugs. Maybe it is a different set of the patients who come to you getting prepared for surgery. Most of our patients, in fact, this is the data all over the world, that 5% of those who require surgery for reflux ultimately undergo surgery. So you have a yawning gap of 20 to 30% of the patients who need surgery, who do not respond to the conventional PPIs or PCAP. What do we do to them? So this is a subgroup of the patient who either are reluctant to use PPIs because they are worried about the long-term safety. Imagine if 18-year-old boy or a girl who is obese, has reflux, how long do you expect her or him to take the medicine for how long? There are 20% of the patients who are insensitive to PPIs or who are not responding to PPIs. And then there are subgroup of the patients who are not fit for surgery. Like Dr. Praveen said, that in obese patients with hernia, they like to avoid surgeries and do something better. And hence this concept came for history of endotherapy in surgery. I am just quoting Hogan, who said, similar to the holiday turkey, esophagus was stuffed, stitched, and baked by the enthusiastic endoscopist intent. So I'm sure most of you would agree that at times a lower Dr. Rajendra is here, he was with us at AIMS, Dr. Bal was also with us at AIMS. We were using bulking agent to augment the LES. These included Antrex granules, submucosal implants, suturing techniques like endostitch, injection of the collagen or glues, or radiofrequency ablation, radiofrequency induced fibrosis of the lower end of the esophagus to give some technique of trying to strengthen the lower esophageal sphincter. And these are the currently available therapies for treatment of reflux esophagitis using endoscopic technique. You have RFA, which was shown by Dr. Dibroshi, in which you cause submucosal fibrosis in the lower end of the esophagus that leads to remodeling of the LES that tends to augment the pressure at the lower esophageal junction. And we have this new technique called TIF, which I am going to show you. We at Gangaram are also doing two more techniques called ARMA, anti-reflux mucosal ablation and anti-reflux mucosal mucosectomy for treatment of reflux esophagitis. So what do these endoscopic therapies do? They decrease the distensibility of the LES to prevent shortening and the loss of the LES competence. They reinforce the sling fibers at the GE junction. They locally alter the vagal neuromodulation of the transient LES opening. As I said, transient repeated relaxation of the LES is very important for the upcoming acid. If you are able to modulate that, you may be able to help the patient even without surgery. So why endoscopy is needed in patient with reflux esophagitis is possibly because it is less invasive, it is cost effective compared to the surgery of patients who are on prolonged PPIs. It gives you good control of the reflux esophagitis, relatively safe, and improves the quality of the life. Now, who are the candidates for endoscopic therapy? As Dr. Praveen very confidently told us these are the patient who should have fundoplication, and then there are a group of the patient who should not have fundoplication. So our indication for endotherapy in reflux are patients who responds to PPI therapy. That means his problem is related to acidity. Secondly, he is not willing to have a prolonged, lifelong therapy with PPIs. He has a mild degree of reflux esophagitis. If it is a severe degree of reflux esophagitis, endotherapy will not help. And he has a small hiatus hernia. That means Hill's grade 1 and 2. So severe esophagitis, large hernia, it is surgical baby. And in the patient has a small hernia or a mild esophagitis, we can do an equally good job. But you have to be sure that the patient is responding to PPI, as well as the fact that the acid exposure time has been documented to be more than 4%. At the same time, as an endoscopist, we should know which patient should not have an endotherapy. Patient with scleroderma, that means those with altered esophageal motility, patient with history of esophageal or gastric surgery, patient with esophageal motility disorders like achalasia cardia or esophageal spasm of the esophagus, patient with Barrett's esophagus or patient with esophageal varices should not have surgery related to endotherapy. So endoscopic therapy of reflux may be a way forward if we have this option. This was a conventional radiofrequency ablation. The technique is very simple. What we do in this technique is that you take a radiofrequency catheter, somehow it is not working possibly because of the codec. It goes at the lower end of the esophagus and 2 centimeter above and 2 centimeter below the G junction, you have this radiofrequency wave which go and injure the submucosa, which once it heals by fibrosis, tends to modulate the LES and tends to increase the pressure at the lower end of the esophagus. So transferring targeted radiofrequency energy to dysfunctioning LES tends to improve the functioning of the LES and tends to improve the symptom. And these have been the results which are available over a long period of time. 70% of the times you may have improvement in the symptoms. Even if the reflux comes up, you continue to have improvement in the symptoms. So this is something which has been established over the last 10 years. We have this new technique called transoral incision-less fundoplication. Dr. Praveen has very elegantly showed how this works. We have another technique endoscopically in which what we do is we go inside the stomach, again because of I think problem with the Kodak, this is not working. You go inside the stomach and make a retroflexion move, pull the fundus into the scope and then use 270-degree wrap to produce a fundoplication like what surgically is being done laparoscopically. So this is called transoral incision-less fundoplication. So this gives you a wrap, something like 270-degree wrap, which has to be 3 centimeter into the stomach, and this is what it looks from within the endoscopy. And it has been shown that this procedure has a significant effect on decreasing the symptoms, regurgitation and heartburn for as long as 10 years over a period of time. So emerging indication and application of TIF are in patients who after POEM surgery, it has been published recently in NEJM also that 20% of the patients who undergo peroral endoscopic esophageal myotomy for achalasia, they tend to have reflux. So this TIF is also useful in a subset of the patient who tend to develop reflux after endoscopic peroral myotomy. If they have reflux, you can do this TIF procedure. And finally, we have this new technique called ultrasound surgical endostapler, in which what you can do is you can go inside the stomach, use an endoscopic ultrasound, try to focus the muscle in the lumen of the esophagus, in the lumen of the stomach, and using the ultrasound probe, you can produce injury in that which heals fibrosis, resulting in significant control of the symptom. There are results which are available for 4-year follow-up with 50% response. And finally, this new reflux procedure, which was developed by Dr. Hinoi, is called anti-reflux mucosectomy. What you do is you go inside the stomach and burn this area, the submucosa of this area using a argon plasma probe. We have been routinely doing this in Gangaram Hospital, and you leave 1/3 of the area untouched and 1 centimeter away from G junction and at a depth of about 1.5 centimeter. If you do an submucosal injection and try to ablate that region going into the submucosa, and as the healing occurs, it will by default heal by fibrosis, and this will result in of a scarring of the area. And then finally what happens is, if you see the results after about, this is the first case which was done as ARMA after, by Dr. Hinoi in a 30-year-old man. This was the first G junction which was patulous after doing an ARMA. 1 month later you can see a tight wrap, which this gentleman showed 10 years later, continued to have the same response 10 years down the lane. And 12 years later, Dr. Hinoi had shown that you have still same tightness of the wrap which was produced because of the causation of fibrosis at G junction. So anti-reflux mucosectomy is another relatively new technique in which instead of burning it with, or instead of coagulating with organ plasma coagulation, you can do a submucosal injection and try to remove the submucosa. And once you remove the submucosa, you let it heal, and with healing you can produce the same results. In fact, this has been the recent publication of utility of this procedure in patients who have reflux after surgery. And it has been shown that after surgery, if you tend to do reflux procedure in the same setting, you may not require a laparoscopic fundoplication in some of these patients. So this new technique is called POEM-F, or fundoplication being done during the same technique. Again, I think there's some problem in the video codec. So in this technique, during POEM, you can take out your cannula, make a puncture, go into the peritoneum, catch hold of the fundus, bring it to the lower end of the esophagus and make a suture which stays there. So this is called POEM-F, or POEM, peroral endoscopic esophageal myotomy, coupled with fundoplication in the same sitting. So this is how it looks like after surgery. Before POEM you had this, and after POEM you tend to produce these results. To conclude, ladies and gentlemen, current data for endoscopic therapy of reflux esophagitis supports clinical efficacy and safety. The procedures are still in process of development. It is minimally invasive, usually outpatient basis, and has been gaining popularity over the last few years. We at Gangaram Hospital have done more than 50 of such procedures, primarily anti-reflux mucosectomy, anti-reflux mucosal ablation. Partnership between endoscopists and surgeons, and I'm happy we have large number of surgeons from Gangaram Hospital, and we have a close association. We talk to them, discuss with them, and finally take a call before offering them any therapy. Partnership between endoscopist and surgeon to treat an anatomic defect, thus eliminating the need for suboptimal drug therapy, which is in the form of PPI. And we fill a void in current anti-reflux therapy in which the patient may not be willing for therapy. So overall, ladies and gentlemen, we know that reflux therapy may be responsible, including behavioral and dietary modification in majority of the patient. Surgery, which all over the world is done only about 5% of the patient. So there is a big yawning gap between the two, surgeons and the physicians. And this can be easily filled if you have a patient, especially in a patient with refractory GERD, who is not responding to medical therapy, who is not willing for surgery therapy, give a chance for endotherapy. Thank you.
Thank you, Anil, for a very informative presentation. And I'm sure everybody has gained out of it, because many things I also did not know. Dr. Vicky.
Thank you, sir, for taking us to the frontiers of endoscopic management. Just one question I have in my mind. Yes. That is, how much is a concern of continued biliary reflex in a patient who's responded to PPI? Is it a risk factor for subsequent occurrence of Barrett's and CA?
Yeah. You see, once a Barrett, I think Dr. Ratna had also alluded to the same question. Once a Barrett is almost always a Barrett. That means you have enough of reflux, enough of sensitive mucosa, which is likely to get metaplaced from squamous to columnar epithelium, and it is a perpetual problem. So once you have a patient who has a Barrett's, he requires a lifelong surveillance. Answering your question, how frequently do you surveil? It depends on the degree of metaplasia. If the patient has no dysplasia, you don't need to monitor it more than, say, after every 2 to 3 years. Low-grade dysplasia, you may need to monitor them after a year. But if it is moderate or high grade dysplasia, then you have to repeat it after 6 months. If 2 consecutive high grade dysplasias, it is better to do some definitive procedure. And luckily, we have excellent procedures like submucosal resection and as well as endoscopic submucosal dissection for removal of this Barrett's epithelium. Because everybody knows, and I think this is a conventional teaching since decades, that surgery does not prevent the occurrence of the Barrett's. It's unfortunate for the patients. That means the reflux will continue, and hence you have to fall back upon PPIs again and continue the surveillance depending upon the degree of the metaplasia in the columnar epithelium.
I have 2 comments to make. I'll be coming in between dinner and what I'm asking.
Yeah.
One is that like laparoscopy taught us that what we were doing in open surgery was much more than probably what was needed. What I see from your things is that probably endoscopy is showing us that we're doing much more in laparoscopy than is really needed.
Yeah.
Because while we talked about a proper shoe shine maneuver, here just with the stitch fundus is being brought down, so probably we need to rethink there. Another thing that I fail to understand is that how is it by fibrosis that you are saying that you're able to control reflux? Why I'm saying so is that God made such a functional sphincter around the lower endosphincter that the angulation and the musculature there was playing a part. When you cause fibrosis by Bernoulli's principle in physics, the speed of flow through that small opening should be much more and should travel a larger distance as compared to a larger diameter. So I'm unable, to my mind, if the speed of flow is high, the acid will flow at a much higher level, and you should get a Barrett's at a much higher level with reflux than fibrosis decreasing Barrett's.
Yeah, I think it's a very thoughtful question, but if you can go back to what I had presented, I had specifically used the word called remodeling rather than causing narrowing. The purpose is not to cause narrowing. Purpose is to remodel. If you see the RFA, what it does, it causes submucosal fibrosis, not at the lower end of the esophagus, but in addition also 2 centimeter down into the down into the stomach beyond G junction. So this is a complex apparatus called lower esophageal sphincter, which is not LES as alone, but it is also lower end of the esophagus, crura of the diaphragm, and angle of his. All that constitutes as a complex, which is remodeled. So that is the reason I've been repeatedly using this term, that we are trying to remodel the LES rather than physically decreasing the space.
For our benefit, would you like to compare PPI with PCARB, this new kid on the block, how effective it is for reflux, and how is it going to change the practice?
Yeah. In fact, this PCABs are the new class of drugs which suppress the acidity. PPIs are the proton pump inhibitors. So there are 3 ways by which the acid can be produced by the parietal cells: by stimulating the gastrin receptor, histamine receptor, and the acetylcholine receptors. All 3 incoming stimuli have to go via proton pump to produce an acid. So when proton pump inhibitors came in, everybody thought that is the end of the problem. You will never have acidity. Because proton pump inhibitor by definition will irreversibly bind to the proton pump until the cell is dead, that is parietal cell is dead and is shed into the lumen of the intestine, they will keep on binding to it. We thought there can be no better drug ever available. But the problem with currently available PPI is that they will be blocking the proton pumps which are active and not passive. Because these drugs go into the circulation, they are acid labile, they get absorbed into the blood and come back and act on the acids which are active during feeding. That is the reason all PPIs have to be given half an hour before meals. That was the drawback. Now this PCAB is called this is a potassium channel acid blocker. Now advantage is that they are acid stable. That means they will go into the stomach and immediately act on the proton pump inhibitor. So they don't go into the stomach, absorb into the intestine, come back into the parietal cell through the blood to act on the active receptors. So PCABs will act immediately within the stomach and will act both on active as well as the passive receptor. So overall, the capacity to produce acid and suppress acid will be far more with PCABs. So they are rapidly acting, they are more potent, they don't need to be given fasting, and the biggest advantage is that they do not get metabolized through this cytochrome P54, P450 cytochrome, which is the mitochondrial enzymes. They have a different way of metabolism, and hence they do not have interaction with antiplatelet agents like classical clopidogrel. In fact, it was said that if you give drugs in combination like pantoprazole with clopidogrel may not be active, and you can precipitate an attack of MI, because people at our age will have multiple problems. You will have acidity, you will be given aspirin, you will be on anticoagulants, antiplatelet agents. So the drug interaction is minimal with PCAB, potency is higher, you don't need to give it fasting, and the action is quick. That is the reason they are almost replacing the market of PPIs. Problem is, since this drug was discovered by Japanese, and Americans typically will not give any leverage to anything which has happened outside US. So they have been publishing their data since 2011, and only I think last year they have recognized that this is a drug which is much better than PPIs, and hence it is a totally new class of drugs, possibly which is replacing the PPIs. Almost for more than 1 year. In fact, they have their own safety profile for more than 10 years. Had it been discovered in US, it would have been in market 10 years ago.
Thank you, Anil. And I think, yeah, Praveen, last question.
Most of the time, both of us had a debate on ecclesia cardia. We were in favor of poem and we were in favor of cardia. The point which we used to score was that in our surgery, the reflux is not there. Do you foresee by the addition of poem F, the reflux will go off and we will not be able to do Heller's cardiomyotomy?
Yeah, yes, I think that is a very relevant question. If you look at the poem in North India, Ashish is there, he'll corroborate with me. We have the largest experience of having done endoscopic treatment of ecclesia with poem. We have almost 600 cases of poem which we have done. Even though literature suggests that 20% of them have reflux, but depends on how do you define reflux. If you do 24 hours ambulatory pH monitoring, who is normal in a person who has no symptom, you will have reflux. But I will not treat that, because as we discussed in the morning also, the sine qua non for management of reflux is it has to be symptomatic and it has to be significant for the patient to complain. In fact, in our cases, Ashish will corroborate that, I am yet to see more than 2 patients who have reflux. So it's almost non-existent. And then even if it is there, that is the reason we do not do poem F routinely, because it is a complicated procedure. Because as a surgeon, as a gastroenterologist, if I see a peritoneal cavity, first thing I think is of you, because the moment you see a peritoneum, for any endoscopist, you look for a surgeon like Dr. Rawat, Dr. Ashish, Dr. Malik. You really, you lose, this is where do you find that calm in the chaos? We cannot find, you are a surgeon. Maybe Ila will tell us how to find that.
I think we are running 1.5 hours late and we are getting messages from the organizers. We stop right now. We'll discuss it over the dinner.
One question. Dr. Anil Arora, my name is Dr. Vijay Anglu. You spoke about cardiomyotomy. Yes, Heller's myotomy.
Yeah.
We do by laparoscopy, we use a door procedure, right? Or we do a push-X because it reduces the reflux. Do you think that this F procedure is comparable to the results of the Number one.
Yes.
Number two. Whenever we do laparoscopic hiatus hernia repair, whether it is fundoplication or whether it is push-X procedure.
Can you use the mic?
Whether it is a fundoplication. Now, in fundoplication, there are many surgeons, they mobilize whole of the gastrosplenic area, greater Garo, and they do a shoe shine maneuver. But I have seen that sometimes it may not be necessary to do so much of a dissection, and shoe maneuver can be done without that. When we dissect the hiatus, we ensure that the hiatus is not too tight. And for laparoscopic surgeons, the guideline is that at least there should be the gap of about so much that one instrument can pass through that. But in spite of that, suppose we have done a laparoscopic fundoplication, in spite of that we have found that there is a temporary dysphagia which occurs in patients for about 4 to 6 weeks. Now we have used bisocolofan and some other drugs for this dysphagia. Now this results because of the postoperative inflammation and edema which occurs. The submucosal resection that you said, whether it was using a laser or you are using radiofrequency, since it will lead to a lot of fibrosis, do you think that it will increase the rate of dysphagia in patients who undergo this procedure?
For reflux esophagitis.
Yes.
So we are doing it by choice. We want that there should be some, it is a localized area in the superficial layers of the mucosa and submucosa. It's not going deep into the muscles.
Yeah, but fibrosis will occur because of the mucosa, not because of muscles.
No.
Always, whenever there is a stricture formation, it is the mucosa which is involved.
Yeah.
So whenever you are doing a radio frequency or you are using laser, you are doing a mucosa and submucosa resection. Now, raw area will be created which will heal by the scarring. Now, will it lead to more dysphagia? Because in normal fundoplication where we use show maneuver, even then there is dysphagia which is temporary.
We have this long-term data of about 7 years in all procedures, RFA and other procedures, in which the incidence of dysphagia requiring intervention is less than 10%. So even if it is there, we can always use a boogie dilatation.
Thank you, sir. Thank you so much.
Thank you so much, sir, for a very elaborate presentation and also elaborately answering all the questions. And thank you so much, all our chairpersons, for patiently listening to a really wide variety of talks. And for our last session, I would like to invite on stage Dr. Rajdeep Singh. Sir is the Professor and Head of Unit, Department of Surgery at Maulana Azad Medical College and Lok Nayak Jayaprakash Hospital, New Delhi. And as panelists, I would like to call Dr. Sanjeev Singhal, sir. He is the President, Delhi State Chapter ASI and the Senior Consultant and Head, Department of Surgery, Northern Railway Central Hospital, Delhi. Dr. Soumitra Rawat, sir. Sir is the Head of the Department of Surgical Gastroenterology and Liver Transplantation at Sir Gangaram Hospital, New Delhi. Dr. Ashish Kumar, sir. Sir is the Professor and Senior Consultant, Department of Institute of Liver, Gastroenterology and Pancreatico-Biliary Sciences at Sir Gangaram Hospital, Delhi. And Dr. Deboshi Sharma, sir, Professor of Surgery, Lady Harding Medical College and Dr. RML Hospital, New Delhi. And the session is on achalasia and its management, any gold standard yet. Over to you, sir.
So thank you very much. So there have been a few changes in the panel. Okay, so the panelists have already been introduced. Unfortunately, Dr. Ashish Vasist had to leave urgently. He was here in the audience just now. So instead of him, Dr. Deboshi Sharma will be sitting in for him. And we'll be talking about achalasia and its management. Is there any gold standard? So as soon as this topic comes in, the question is, which is better? Is it surgery or is it endoscopy? And let's see if we can reach to some sort of consensus here. So it's, as you all know, it's a motility disorder. Delhi has a population of about 33.8 million. So if we take this prevalence into consideration, there should be about 600 to 3,000 persons with achalasia cardia in Delhi alone, equal in men and women, and it's actually a sort of a 30 to 60 age group, it's most common. So these are the common symptoms, and the first three symptoms you would see very often in other patients also. I mean, even with GRD, without GRD, you would still see patients who have heartburn, chest pain, or regurgitation. If you have dysphagia, if the patient gives a history of that, then the diagnosis is much easier. So, Dr. Ashish, with these symptoms, I mean, the first three symptoms, heartburn, how would you proceed to investigate these patients?
So, dysphagia is a very typical symptom, which if there's for solids as well as liquids, then typically it should be investigated first by endoscopy, and then if that is suggestive or even that may be normal in these patients, then we have to go for esophageal manometry.
So many patients, they don't really have dysphagia. I mean, they come with the milder symptoms. So endoscopy is still the first.
Endoscopy has to be.
So as for our students, we always said that in achalasia, dysphagia is to liquids first, then to solids. Is it true? Is it common in your practice?
So they are typical. If there is a mechanical obstruction, then the dysphagia would be for solids first and not the liquids. But in these patients, we have patients having dysphagia for both solids as well as liquids, and they have symptoms of regurgitation, very common.
Right. Okay. So you talked about endoscopy, the typical findings you would find, I mean, most common findings.
So endoscopy may be normal in many of these patients, but sometimes you'll find if the esophageal is dilated, then lots of food residue as well, and there'll be difficulty in passing the endoscope from the from esophagus into the stomach because of the tight region.
So patient comes and the endoscope is difficult to pass. I mean, it's more than normal difficult. What would you think then?
I think the typical thing is if you are doing the endoscopy regularly, what happens, you need to push to pass into the stomach. That is achalasia. Normally it goes very easily, and even if you don't find a narrowing lower down, but you have to, like Dr. Ashish has said, you need to make a push to go into the stomach. That's one. Second thing he has said is, you will find the dilatation of the esophagus, which is hallmark.
Yeah, if you get that, then it's easier. And retained saliva or some food, something.
Then, as Dr. Ashish has said, that, once you have ruled out malignancy in dysphagia, that is why the first thing is endoscopy.
So if you don't have these hard signs like difficult to pass and a dilated esophagus, do you think there's any role for a pH metry in this way? Yeah, absolutely.
pH metry has not a definite role in these patients because manometry is the most important test for these patients because that would actually clinch whether it is a motility problem or it is mechanical.
So I was just thinking that these patients come with
I think just to make it clear, pH is, Dr. Anil Arora has said that if you don't fit into the Chicago classification, then you need to do the pH.
Okay, so manometry should...
For dysplasia, pH, it can be added as when you are sending for manometry, you can have a pH also because that will decide what kind of fundoplication you are going to do.
Right.
So it is a adjunct to it, but not definite for the diagnosis. That is a manometry. So
like
you need to have a clarity.
So manometry, like you said, is the gold standard. So would you like to discuss, I mean, for the layperson, how to read these?
The more red you see, most is the problem. What happens is in an achalasia is that the whole esophagus is devoid of the plexus, right? And because of which there is a failure in peristalsis and the failure of relaxation of the lower sphincter. So when the food bolus goes down, there is failure of relaxation. That is what is the pathology is. The type 2 one is the most commonest type, but nowadays we very rarely see these type 2. If you operate 5 cases, previously 5 out of 5 used to be type 2 cases. Now you don't see those type 2 cases, which are mostly done by the third space endoscopist.
So that was I wanted to ask. Do your patients come through the gastroenterologist or they have the primary?
The long segment one comes from the gastroenterologist. The sigmoid one comes from the gastroenterologist, but definitely they try to do something in these short segment type 2 ones.
So that's why you are
they
not
do at least they do a dilatations. They do dilatation, and then when they do not improve after that, they do come.
That's why you're not seeing the classical...
Then, when you have a good endoscopy, because in our place, poem is not done very frequently. They do 1 or 2 cases of poem, but not very frequent. But other cases, they do the other procedures. They definitely do the dilatations, which doesn't help much, but still they do those in type 2 cases.
So when would you get a barium swallow, sir, Dr. Singhal?
To be
Does
very
it have
frank,
a role
let me
now?
profess my ignorance. I have not operated any ecclesia ever in my life.
Okay.
So I have seen cases, but I have no personal experience, so I would not really like to comment.
Dr. Awadh, when would you like to get, okay, the best. Yeah.
Barium we don't do. We do a gastrographin study. Barium, the problem is that barium, to take out that barium is very difficult. It gets stuck there sometimes. You cannot do an endoscopy after the barium because it gets stuck with the endoscope. The endoscope gets, there is a problem with the endoscope. We don't do a barium. We do a gastrographin study. That tells you the width of the esophagus. That tells you the length of the stricture and tells you another things. But
You mean in all patients?
we do a gastrographin study. I personally do a CT gastrographin. CT gastrographin that tells you many things, and definitely to look for a pseudoachalasia, which is malignancy, endoscopy is the best. Sir wanted to say.
No, I think you have, majority of time, our patient comes from other place, from the district or a small town, and they will have a barium swallow.
But
They
if
will
it's
have-
not there, the HRM shows that it's a achalasia type 1 or 2.
Then
Do you
barium
need
swallow.
a barium? It's not needed.
It's normally not needed, but then if you are thinking about nutcracker or if you are having a spasmodic, then barium swallow does help.
I'm
Does
sure
help.
they would have already done all that and gives you it's a type 2 achalasia. So, I mean,
Then,
nutcracker is
then
out
it's
then.
fine. Then it's fine.
But a surgeon
Sometime-
always likes some anatomical.
Sometime what happened when it's a sigmoid esophagus, then you know what is the extent.
So that's a definite indication.
That is one. And sometime in sigmoid or whenever you are doing a redo surgery, which, I've done quite a lot while I was in UK, we used to be tertiary center, I will always get a barium swallow to look into the whole thing or the CT with oral contrast.
Yeah, CT. So, and for recurrence also. If there's
Some kind of a contrast study has to be done. That is what
Has to
we
be
don't
done.
use the salt barium. We use a gastrographin.
Same, I
this
use
is
a
the CT which we are
gastrographin.
talking about. Okay. So, pseudoachalasia is obviously malignant when there's a mechanical cause for obstruction. That has to be ruled out. Okay, so I think Dr. Ashish can take that. We talked about the Chicago classification in the earlier lecture also.
So in the previous manometry you had shown, there are 3 types. So the typical of achalasia is that there should be increase in pressure in IRP should be high and there should be absence of peristalsis. So the absence of peristalsis in all 3, but in the type 1, there is obviously 100% failed peristalsis, but in the type 2, there is also, in addition, there would be pressurization at least in 20% of the swallows, and the type 3, there would be spasmodic spasms in between. So this is the way we actually classify. This is the Chicago classification. And if we have all the typical features, then this is obviously achalasia. But if we just have, if few of the peristalsis are present, then we call it esophageal gastric EJG obstruction.
Yeah, but how does it help the clinician? I mean, it's a type 1 or 2
So
or 3.
it guides the therapy. For example, type 1, for example, type 3 will best respond to POEM therapy. In type 2 and type 1, we do POEM, but type 2 will also respond to even pneumatic dilatation.
So that's why it's important.
Rajdeep, type 2 is surgeon's delight.
Yeah, I know.
And type 3 is gastroenterologist. For gastroenterologist also, type 2 is the most delightful, but that's where they are fighting with the surgeon. But for type 3, surgeon will raise the hand and say, carry on, the gastroenterologist. Because the results are definitely better. Because you need to do a longer myotomy, very high up.
So I'll, just for coverage, we talk about the medical management also. Do we really give medical management nowadays, sir?
No, medical management has almost no role, only for very reluctant patients or very elderly patients who are not ready for any invasive procedure. We do
give, but that hardly gives any relief. That is my personal experience.
Yeah, that's what.
So,
Botulinum, have you ever used botulinum?
So that will come in
Botulinum
endoscopic.
is the next thing.
That
but
will come
this-
in endoscopic. So we have the endoscopic management, which is primarily of 3 types. So we'll take each one of these. So the last one has come a decade or so ago, if I'm right, at least in common use. But what we have more commonly earlier was pneumatic dilatation. We just give pressure, put a balloon, give pressure so it dilates, causes uncontrolled rupture of the fibers. I take it akin to like the Lord's procedure for fissure in NO, where the dilatation of the sphincter was done and the muscle fibers were broken at various places. We never knew where, which has been replaced by sphincterotomy, which is cutting the muscle at one site only. What about pneumatic dilatation? You must have a lot of experience with that.
So this has been there for a long time now, many decades now. We have been doing this, and it due to radial pressure, it tears the, and it has got very good response. Up to 80 to 85% of patients used to respond. Till the POEM procedure came, this was the standard procedure, and we used to do, and some of these patients used to require repeated dilatations after, if they have recurrence of symptoms. But many would have respond even to single session also, but some of them do require many sessions.
What about perforations? I mean, what the literature says is
See, for pneumatic dilatation, I did pneumatic dilatation for about 15 years in UK, but now our gastroenterologists, they do it. It is good, and I will say, like in India, UK also, gastroenterologists will give achalasia to you once they have done once or twice pneumatic dilatation.
Have you had any
Now we don't get it because POEM is there. Previously we used to have almost once in a month.
And did you have any problem doing a Heller in these patients post dilatation?
See, it is difficult. It is difficult. The more pneumatic dilatation have, up to 2 is fine.
Okay.
But once you go beyond 2, then it's difficult. Like in UK, gastroenterologists most likely, say 90% of them, they will give it to you after 2.
Okay.
After 2, because then the risk of perforation increases, and they will give it in a fit patient. Suppose if the patient has got a lot of comorbidity, then they carry on. But there is definitely 1% risk of perforation. This is what you need to tell the patient. And the pressure is very important. It has to be, my gastroenterologist will say, has to be 30, isn't it? So normally gastroenterologists, they will put it 30, and then second time in the same one, they will increase it to 35. Some of the gastroenterologists, they may increase it to 40, but they won't go beyond 40. So 30 is must.
So this is 3 centimeter, 3.5 and 4 centimeter balloons, which I'm told. I've never done it, so whatever you say is fine. And what Dr. Debarshi was talking about, Botox. Dr. Debarshi, you have any experience or any?
I don't have any. That is why I was asking. Because Botox patients post-op are difficult to do. That is one thing I know about because I've done 2 cases.
So Botox is given only very elderly patients who are not fit for the POEM or the pneumatic dilatation with lots of comorbidities. It's a temporary procedure. There is symptomatic relief in about 50 to 60%, but it is not long lasting, and the patients usually get a recurrence within 3 to 6 months.
So I think it's clear that it's not the primary procedure, preferred procedure. And then we have POEM. So we'll just take it quickly through what exactly POEM is, because many people would not be knowing what POEM is.
Yeah, I would, for that, I would in fact request Dr. Anil Arora, because he has got maximum experience of POEM. So would you like to take this, how it is done?
His mic is there.
I think there is an excellent slide which has been projected by Dr. Rajdeep. So if you see the first film, this is a totally new concept called third space endoscopy. And I'm lucky this was discovered by one of my seniors from AIMS, Dr. Pankaj Pasricha. So we knew of only 2 spaces till then. that was in 2009. One was the space in which we were going as an endoscopist to do endoscopy, colonoscopy. That was space 1. And then there was a space which was used by the surgeons to do their procedures, like open up tummy, you have laparoscopy, balloon it up and do anything. So nobody knew of this space called third space. So Dr. Pankaj Pasricha, who was 1 year my senior at AIMS, 1979 batch, he thought, he was a brilliant researcher, he was in Texas, so he thought of a new concept of creating a space between the lumen of the, say, stomach and the peritoneum. So you had these 3 layers of the GIT wall, you have the mucosa, submucosa, muscularis propria and serosa. So he created a tunnel between the mucosa and the submucosa. So by creating a tunnel, you push the mucosa anteriorly and push the muscle posteriorly. So you create a tunnel like in the first picture. If I can show you here. So what you do is you enter the lumen of the esophagus, inject some saline and then inject fluid so that the muscle comes anteriorly, the mucosa comes into the lumen and the muscle is pushed posteriorly. So you have created this tunnel. This is called submucosal tunnel. And using this tunnel, you have made entry in the upper esophagus and you have created a tunnel all along the esophagus. Then muscle has been pushed back. Now you cut this muscle like what the surgeons do during POEM. Once this muscle has been cut, that means you have achieved a myotomy. The difference between achalasia, surgical and POEM is that as a surgeon, you will start here and then you will be able to extend your myotomy up to this place. Whereas we guys are coming from the top and going right deep down into the esophagus. So once you have cut the muscle open, you come back, take your scope out and then try to clip this with the help of clip. So within next 24 hours, patient can be discharged. This is in which you have close this tunnel because now your food, because this was only a mucosal incision which you have stitched, muscle has been totally severed in a longitudinal manner and now you have a lumen which is totally patent. So within 24 hours patient is able to go. This is a concept called third space endoscopy. And thanks to his discovery, he did it in pig. He did not do it in human being. That was in 2007. Then there was a gentleman called Dr. Hinoi who discovered ARMA procedure for reflux. He did the first case in 2008 in human beings. And since then, it is a total revolution of a new field. So all submucosal lesions, including leiomyomas, gastrinomas, neuroendocrine tumors, or gastrointestinal stromal tumors, which are located between the muscle layer, we can create a tunnel and take them out. So this is an absolutely new, brilliant field of third space endoscopy. And POEM is one of the classical examples of that.
And just, Dr. Arora has explained so well, that is why, we as a surgeon, we cannot go above the inferior pulmonary vein. That is, the highest you can go. And for type 3, they start from where exactly is the aortic arch. So it's a very long myotomy. That is why for type 3, POEM is the treatment
best.
of choice.
Yes.
No, because he has explained it, that is why I'm saying.
The two relevant question is when to suspect achalasia. As an endoscopist, I think it is very important to ask anybody with a clear-cut symptomatology. If the patient says he has dysphagia, it can never ever be normal. Anything can be functional but dysphagia. And to begin with, the patient will have difficulty in swallowing the liquids, not solids. And anybody who has a food which comes from the nose, it can never be a reflux. So the contents coming out through the nose, gastric contents, and difficulty in swallowing liquids, not solid. That is the first clue. And as soon as you do an endoscopy, as Ashish said, so many times endoscopy is normal. But if you see liquid at the lower and at the posterior wall of the esophagus in a patient who is fasting, that is the first clue. So presence of fluid in the esophagus, nasal regurgitation, these are the things which you have to be really alert, because most of these patients are wrongly diagnosed to have reflux and they are treated as reflux. When they do not have reflux, this is more of a regurgitation. So subtle 2 points if you have to go with the carry home message: nasal regurgitation and presence of fluid on endoscopy, this is a subtle clues to presence of achalasia.
Absolutely. And if you look at signs and symptoms, if you are looking at symptom, 60-70% of achalasia patient, they have a regurgitation. And 25-30%, they will have a pneumonitis and, cough. Recurrent aspiration. Because when they are sleeping, they don't realize they've got an obstruction and esophagus is full of food debris.
Yeah. So as expected, the GRD would be there, and we'll talk more about that later. Now coming to the surgical management. So you were talking it Botox makes surgery difficult, Dr. Devarshi.
That's means you asked about pneumatic dilatations and all. There's a little bit of fibrosis around it, but hardly you can make out in how many times it is you have dilated.
Doesn't
it.
make a difference.
Then
What's your experience?
once you go ahead, and in some cases when there is little inflammation, it's very easy to get into that plane also.
I think if you are in a right plane, I've done quite a few patients after Botox and pneumatic dilatation. I think if you are in a right plane, then you don't. I think there the surgical trick is don't do the myotomy at gastroesophageal junction. Go higher up. So in those cases, what I will do, I will go about 4-5 centimeter above the gastroesophageal junction, open there, find the mucosa, then come down.
Okay.
That is a trick. And suppose if you start just 1 centimeter above the gastroesophageal junction after pneumatic dilatation or after Botox, you will perforate mucosa.
Right.
It's always easier to start above, actually.
So that always used to be the thought that surgery is more difficult. What does the data say? 1999, long time back, the lower esophageal sphincter muscle had become fibrotic. There are other factors also. In interest of time, I'm going faster here. Say in 2006, more or less the same. Failure of myotomy was higher in the endoscopically treated group. But now POEM comes in. So earlier it was just Botox and dilatations. But now POEM has come in. After POEM, similar results in patients with and without prior endoscopic or surgical therapy in 2015 now. Favorable outcomes following POEM. And again 2016, prior treatment does not influence the performance of early outcome of POEM for achalasia. So if we are cutting the same sphincter, endoscopically it has no effect, then I'm sure the surgery also would not be so difficult. That's why the recommendation, this is the ASG recommendations. It does not significantly affect the surgical as well.
Also, to just tell you about it, when they are doing a POEM, when we do surgically, we go maximum 7 centimeter above the gastro. And when they are doing it very high up. So they are going into the virgin field, and when they are coming down, it's easier. That is why
that's a big point. So how, she's told it over 7 centimeter, what is your extent of myotomy?
It depends on the length of the structure, length of the segment of it's never less than 7, but I've gone up to 12, 13 also, particularly the ones in the which have a sigmoid esophagus. Sigmoid esophagus, what we do is that we see the G junction and see the sump of the dilated DA. The option there is that these are patients which might have failed POEM. The next option is to do a esophagectomy. So these patients given option of a myotomy, a long myotomy, which we call it extended Hellers, will mobilize the whole of the lower esophagus, so that ultimately when you do a myotomy, it becomes like a funnel. First, the sump cannot be below the G junction.
Naturally.
The sump cannot be on that gastrograph, and it is going to show you. If the sump is above, then only it is going to drain. So in those, you go up to the dilated part, and then I've gone up to.
If it's not a sigmoid esophagus, then usually 6 to 7
centimeter.
I think, Rajdeep, the most important thing is when you have a recurrence, when you look at a recurrence, the problem is, you haven't done the 2 centimeter into the stomach. So that is where all the recurrence happens. So that, you have done the esophagus up to 7, 8 or 14 centimeter, But if you haven't gone down 2 centimeter, that's where the recurrence happens.
Yeah.
So 90% is not because of esophagus. In type 2, if you do up to 5, it's fine. But you have to do 2 centimeter into the stomach. So my thing is 5 to 7 centimeter on esophageal side and 2 centimeter on the stomach.
So about 7 to 9 centimeter you would say.
That depends on the reflux also. The reflux also is determined by that 2 centimeter.
And the trouble what happens when you come from up to down, esophageal muscles, you can clearly identify both the muscles. When you come to the stomach, you got a crisscross muscle fiber. That's where the problem happens.
And
So you need to be careful and you need to go 2 centimeter down.
Below, yes.
That's the thinnest part also.
Yeah. So, many ways of doing a surgical myotomy. What do you prefer? You can start.
Maryland forceps.
Okay, okay. So you just like tear it apart.
So what, I will go with Maryland, just separate the muscles and then tear apart. Once you have done the initial bit, then I will use a harmonic, but I will put the active blade anteriorly, passive blade posteriorly, so that active blade is not in touch with the mucosa. That is the most important thing.
And special bipolar forceps are also, scissors are also available if you wish to divide it using those. Do you confirm the completion proper adequate myotomy?
No.
See, I always get a gastrograph in next day.
Next day.
Next day. On table, what I do is I always do the leak test. Sometimes I put a gastroscope also. Leak test, I always do it. And I think it's very important to do a leak test. In one of the patient, you couldn't see the mucosal tear. On a leak test, there was a very small. So that, we saw it, closed it, door fundoplication, billing.
You would also do it?
We don't have an endoscope on the OT table, but the endoscopy is done to look for the completion of the myotomy as well as for the leak. There are 2 indications of doing it.
Yeah, so
you
what
can
I
see
wanted
those
to know is
fibers,
the
you can
real
see
world
those
experience.
transverse fibers across which you can pick up and
No, what I wanted to see was the real world experience. But do you have an endoscope in the OT?
We don't have an endoscope, but definitely we do a leak test with the patient before
Leak
doing the
test.
fundoplication.
Okay. Right. So what about fundoplication?
See, I will look into the symptoms of the patient. If the patient previously, normally in UK, we will do the pH manometry along with the, along with it. And if the pH manometry shows that there is a reflux, I will do the toupee. I will do the toupee 270. Though that is what I normally do. I will do a toupee along with the Hellas myotomy. But then in select cases where, you are like the hole in the mucosa, that is the time I will do the door.
Okay.
But I will never see the 2 problem happens. One I have told you, not going 2 centimeter into the stomach. That is one, and the single most problem of when you are doing a redo. Second is when a surgeon does 360 wrap.
360, okay.
360 is Nissen.
Yeah, should not.
So in an old time, a lot of surgeons in UK, they were doing a 360 and they will say 2 centimeter wrap. And then when they require surgery for dysphagia, that is where the 2 things, the most common in 75% of the cases, one was not an adequate length of 2 centimeter into the stomach, and second was 360 fundoplication.
So what you are saying is that if there is no preoperative evidence of reflux, which in achalasia usually would not be there.
But even if there is a reflux, I won't do 360.
No, not 360.
Yeah.
360 is for an achalasia 360
is not,
Is not out.
is
But
not
I'm talking
done.
about a door or a
But
toupee.
then I'm talking about early 1990s when the laparoscopic came in play. So redo, we had to go in after a year, 2 years, 3 years, 5 years, 10 years. So this is a problem which we found out here.
What's your
So these
opinion,
two.
Devarshi?
I'll do a fundoplication in all the cases.
Okay.
And the problem with POEM is that they don't have a fundoplication. That is the only problem with POEM. And because of this, they are devising new devices to do a fundoplication associated with POEM. Now, which type of fundoplication I will do? If there is a perforation, definitely I will do a door. And when I do a door, I always do it with an angle of his attenuation plus a door, which is a part of the procedure. I'll not leave behind any stomach with only an angle of his attenuation. Angle of his attenuation, 2-layered, that's a different technique slightly, and a door, and a toupee also, that's 50-50. Mostly it will be a toupee, but if there is a perforation, we'll do a door definitely. Door is an easier procedure to be done.
Also, for the young surgeon, I will say, if you are doing a door, what you should do is fix the muscle edge with the stomach on both the sides.
Yes.
What happens if you don't fix the muscle on both the sides, they will have a recurrence of symptoms.
Because it closes
Because
off.
what happened, with the door, muscle will approximate with time with the stomach sitting on.
Yes, sir.
So you need to put the stature
Take the bite on the
both the
stomach,
side,
the muscle edge, and the crura.
and the
together.
crura.
Together, 3
So
points,
that,
3
so
point
that
stitches.
muscle is separated.
That's why toupee was supposed to be better because it would keep the muscle edges apart. So let's see what the literature says. Myotomy with and without a door. So this is the initial report. So follow up of 1 to about 2 years. So with the door, it was definitely better. The reflux was much less. The same group reported the long-term reports after 5 years. The same group of patients, not all the patients, but what they could follow up. And they found that there is not much of a difference among the two. There is no statistical difference. So there's a trend that with the fundoplication it's better, but long-term there is not much of a difference. So that means after 5 years...
Have they mentioned the length of gastric dissection they have done, means how much they have cut towards the stomach, whether it is 1 centimeter or 2 centimeter?
No, they said they did a standard myotomy, which I presume would include
Will
2
be more than
centimeters.
1.5 centimeter.
Yeah, would be that much at least. So this has already been discussed, what should be done. Door versus toupee, difference is not statistically significant as far as the results are concerned. Again, another which is actually a meta-analysis database of all the studies, effective and equivalent results. However, if you consider length of hospital stay and quality of life, then toupee is better. Although I don't know, both patients are discharged in the same time when we do it. So maybe there was some mild difference between these two cases. So these are the recommendations. Either
There's a
can
very
be done, it's fine.
beautiful series from Dr. Rajendra Prasad, who was published in Surgery Endoscopy around 2014-16.
Yeah.
He has done that door with an angle of his attenuations and all these things.
Stitch.
So that also could have been covered.
Yeah. So now we come to the crux of the matter. Poem or Heller? Which patient would you send to Dr. Samitra?
So in last about 10 years, we have not referred, I think, any patients for Hellers, and we have been, we have had excellent results, thank to God, and then experienced endoscopists. So we have excellent, and very infrequently we have had to repeat the poem. But most of the patients have got good, long-lasting results, and we score them the dysphagia score, that's called E-card score, and they have got very good responses.
If a patient comes to you, not through the gastroenterologist,
That's
from some
fine.
other city,
That's what happens, they come directly to me, but I'm very honest.
Yeah.
Type 2 and type 1, I will do it.
Okay.
Type 3, I will always send for poem. I will always send
So
for
bottom
poem.
line, that's very
Yeah,
clear.
yeah, because thing is, what you want is what is best for the patient.
Okay.
So,
Another thing is that
So you believe surgery is better?
Sorry?
You believe that surgery is better? Hellers is better?
For type 3. Type 3 poem is better.
Yeah.
Type 2 and 1,
Yeah.
I still feel, because this topic is about the gold standard.
Yeah.
If you look at a gold standard, see, poem success rate is more than 90%.
Yeah, more or less-
Surgery success rate is more than 90%.
Data
Although gastroenterologists do say the reflex is in 20 to 30%. But if you look at objective paper where they did 24 hours pH, it is 50 to 70%.
I agree. So the data says it is 50 to 60%.
Yeah.
When you do a pH metric.
But if the gastroenterologist is speaking, they will say 20 to 30%.
Symptomatic reflux is 20 to 30%.
See, symptomatic is subjective.
Which can be controlled with PPI. That's
So that is what it is. Yeah. So, but
another thing
the paper where they have done a pH, it says 50 to 60%. You are right.
Devarshi?
Another thing about poem is that if you have a failure within, because myotomy is always done at 12 o'clock position. So if you have a failure that you can do a poem, posterior poem at 6 o'clock position. That is one advantage of poem which can be done if you had a failure with that.
Either way, I mean, as a primary poem also can be done posteriorly. And if
a primary poem also can be done posteriorly, it can be done interiorly, but definitely if you have a failure with a Heller's, that can be done posteriorly. That is what.
Yeah, so the data says they are both equally effective. There is not much to choose between the two. It depends on availability of expertise. Heller's, more surgeons can do it. Chance of GERD is the main issue, which is the crux of the matter, like Devarshi said. In poem, there would be reflux. In surgery, there would not be reflux if an fundoplication has been done. So let's talk about GERD. After poem, significantly more than after poem, there's no doubt, nothing strange here. And if there's in this systematic review and meta-analysis, poem was more effective than Heller's myotomy in relieving dysphagia, which is what the patient has come to you for. But definitely there's a higher incidence of pathological reflux. And another meta-analysis, like Dr. Rawat elaborated, for type 1, 2, they are equally effective. And for type 3, poem is definitely better. There's no doubt about that. We all talk about SAGES guidelines. We follow the SAGES guidelines for many. What does SAGES say? In eclasia type 1 and 2, poem is same as Heller's. So whatever you like, you can do. No need to refer to each other. For type 3, poem is much, much better than Heller's. And the pneumatic dilatation obviously is more or less out. Mucosal perforation, we talked, DOR is preferred. In such cases, megaesophagus. Devarshi elaborated that would still prefer a Heller's because the next step is obviously an esophagectomy.
But these patients have to be told that the recurrence rates are high and they can end up with a malignancy. You can have a 10-year period by which one thing is that they will not be fit enough to do esophagectomy later, but definitely most patients will opt for this because that surgery has definitely more morbidity.
So it's like a trial and surveillance has to continue after that. And if recurrence occurs after Heller,
you can do a re-Heller. Nowadays we do a poem if we request for a poem.
Recurrence after poem, we get a poem again.
If that's posterior.
I think it's again the same thing, if it is recurrence after surgery, you send it for poem, or if it is after poem, you send it for surgery. Okay. And the two things which I mentioned, those are the most important thing after Heller myotomy. And you can take care of it. You need to be careful about two things here. One is a perforation and second is a vagus nerve. Yeah. So these are the two things. And the other thing is sometimes I've seen it, cardioplasty, we did it in few patients in the redo surgery with pretty good result, and esophagectomy is the last resort. But cardioplasty, where you have done the cardiomyotomy, you open that, take the fundus up, so you do either the stapler or you do the side to side. This is what is called as a cardioplasty. Okay. So you can do that when you are doing a redo for eclasia.
So it's like a esophagocardiac anastomosis.
Yeah, that's the one. Okay. And then you cut the whole thing because mucosa is there. So you cut the mucosa. So one half of the cut you join with one wall of the fundus and the other one you cover it. So where you don't have a recurrence because you got a very big opening. and you
So
cut the whole
difficult
thing.
procedure, something which Dr. Kriplani described, cholesis gastroplasty. It's easier said than done. This is also something very similar.
People are getting anxious,
I
so
can
please,
understand.
your concluding remarks. You can start.
Naik,
The concluding remarks.
we do hellers for all cases. We do both door and ye, but definitely poem has its place. Only thing is that regarding the reflux which these patients have.
Sir.
So as I said initially, I have unfortunately zero experience of ecclesia surgery, but I still feel that POEM is a very, very highly specialized gastroenterology procedure. Sitting in Delhi, we can talk of POEM. Maybe even if I go to Meerut, you might not find a gastroenterologist who is doing POEM.
Possibly.
A good no, I agree with that. Okay. I just making a small example here. Heller's myotomy, I have done a lot of Ramstead. So Heller's myotomy can be done by a average surgeon.
Okay.
So if we look at a pan-India picture, surgery is going to be way ahead of POEM. Because we do not have enough, and I'm sure you will agree, so many well-trained gastroenterologists that they will be doing POEM. I do not know whether it requires a special kind of gastroscope also. Heller's myotomy can be done with the same laparoscopic or open instruments which we have. I am not sure what kind of instrumentation you require for POEM, maybe you can guide us. So cost is also an issue. So I think surgery is the mainstay in a practical situation in a country like India. And for that to continue, I think gastroenterologists will have to realize that they must give it up. Because otherwise our young surgeons will not be trained enough to do it.
So actually, I have seen privilege of seeing a poem.
I have never seen
a poem being done right in front of me by a surgeon, and let me tell you, it's a very elegant procedure. I mean, you feel like yes, it's a very good thing which has been done.
I understand that.
Right. So,
I think gastroenterologists started doing it because the surgeon arrogance. We didn't venture into it. And I'll tell you, in England, a lot of surgeons, they are doing POEM because they do gastroenterology. They do everything. Like, I used to do all intervention, pneumatic dilatation, everything. But then what happened that, if you are busy, but I must salute our gastroenterologist also, POEM is a wonderful thing.
It's a wonderful
And that is what I'm saying. Our sort of fight is for type 1 and 2. If the patient come to them, they will do POEM. If patient comes to me, I'll convince them for Hellers. But for type 3, definitely not.
So my concluding remarks would be for never miss pseudoachalasia. So that is very important because if there's short duration of symptoms and these elderly patient should have high index of suspicion for malignancy. Otherwise then the standard management remains same, and for type 3 obviously POEM is the best, and for type 1 and 2 we have also done POEM and never.
So I'll leave the audience to draw their own conclusions, right? And thank you very much, sir. It was a very nice discussion. Thank you very much.
Thank you so much, panelists and Rajiv sir. Please wait. We have to distribute the mementos. I would request Dr. C.K. Durga ma'am to please come on stage and deliver the mementos to our moderator and our panelists. To Dr. Rajdeep Singh sir first.
Done so very well, but yes. I request you.
Dr. Sanjeev Singhal. Dr. Sanjeev Singhal sir.
This is your day.
Dr. Soumitra Rawat sir.
You don't forget your England.
Dr. Ashish Kumar sir.
You people have taken away our epilepsy patients.
And Devarshi sir. Thank you so much. And thank you so much everyone for concluding. I would like to invite Dr. Ashish Dey on stage.
Thank you so much for coming forward. Right. Thank you so much, panelists and the moderators. And I know I'm standing between you and dinner. So basically, before we conclude, I mean, before everything finishes, there is the cherry on the cake, the Delhi State chapter winning the Best State Chapter Award. Before that, I'd like to thank the sponsors, the Pantosid division of Sun Pharma, for this, for helping us out in this program. So, Delhi has been winning the Best State Chapter Award for the last 7 years. And as a secretary, it gives me a great pleasure in telling you that it has been because of the concerted efforts of all the executives in the chapter, and more so because of our president, ex-president Dr. P.S. Sarangi sir, who has helped us all throughout the year in getting us to where we were. So I request Dr. Sarangi sir to please come on the stage and get us through the journey of how Delhi became the best state chapter. Thank you.
Thank you, Dr. Ashish. Respected seniors, dear colleagues. As a past president, what I can feel, wow, it is past. When I took over, my predecessors told me, see, the year will go very fast. And now I am completely blown out, as so quickly it disappeared on me. However, throughout this journey, it is one of the most rewarding, exciting, challenging, definitely as a surgeon, ego-pumping, sobering, and educational period of my life. So when I was selected by or elected by our august members of this chapter, so I was little bit surprised and reluctant because I'm a completely professional, not on these type of activities. And then I thought there is some skills which the association requires at this moment to keep the legacy of the state chapter go ahead. Why I was reluctant? Because I was putting my steps in the shoes of those presidents, starting from Durga ma'am and Devarshi as a secretary and ma'am as a president, the best state chapter in national level out of 26 state chapters and many sub-chapters. In the initial period, it was quite a smooth journey, but gradually as the national body saw there are 8-10 states are getting best state chapters, they started tightening their noose and started imposing different bigger challenges. And to cope up those challenges, it was really a difficult journey. And somehow I was blessed with our honorary secretary having Dr. Ashish there and an amazing team which we had and who were always in the forefront to carry out the activities. And when I started, I fixed a few goals, but no end line. So primary goal for myself to keep the state activities in a little higher level from where I have started my journey. And for the state chapter to carry out its routine activities and to comply with the basic requirements of the national level requirements and heighten the educational and academic levels. So to that extent, I feel that getting consecutive 7 times best state chapter award, we have achieved a lot. When most of the chapters were boasting that we have achieved the 2nd consecutive best state chapter, 3rd consecutive best state chapter out of 26 state chapters, we proudly announced that we are winning the consecutive 7th best state chapter. So to achieve that, we have made few remarkable advancement in the level of the state chapter. And in addition to the routine activities, this is a lot of list, almost 26, 28 routine CMEs, workshops and conferences has been done throughout the year all over the state. And the list was announced by our secretary in annual conference. But what milestones we have achieved, that for the first time, Delhi State Chapter has organized a CPR workshop for CRP personnel, where more than 270 personnel has been given hands-on training, and simultaneously all over India, 26 stations were given the basic awareness on CPR training. And in the social activities, for the first time, Delhi State Chapter has gone beyond the state level and has conducted workshop in Andaman and Nicobar Island to exchange our experience with the local surgeons and to benefit the local people. And for that, I am extremely grateful to Dr. Ashish and Dr. Sri Krishna Das. And this is a first time in the history of Andaman and Nicobar Island also. Regarding our academic activities, the responsibility for our different activities were given to different organizers, and I am thankful for conducting those activities in a precise manner with utmost precision. And I am thankful to Dr. Anmol also for carrying out the activities regularly. Regarding the workshop, I must thank Dr. Puneet, HOD Surgery, DDU Hospital, for carrying out 3 cadaveric workshops where we have trained more than 90 surgeons, young surgeons, on different aspects of surgical field, including colorectal, vascular, and thoracic surgeries. One of the great milestone which we achieved is the launching of our own state chapter journal, the Surgery Digest. The journey was really difficult, but it was actually possible with the help of our editor-in-chief, Dr. Chintamani, and our Secretary, Dr. Ashish. And this is a platform which we have given to the surgeons to showcase the activities of our Delhi state in the world platform. For that, I am really grateful to Esophagus CME Foundation, Dr. V.K. Malik sir, Dr. Jowhari sir, for their financial support for launching our state journal. To conclude, I extend my thanks to all my seniors and all my friends who has extended their support throughout my journey. And now I am handing over my baton to Dr. Sanjeev Singhal sir, and I am sure he is one of the most capable person to carry on the legacy, and he will bring the state chapter in newer heights. It will be unfair unless I thank my postgraduate students and my residents who were all along throughout my journey, and also my wife, Dr. Susmita, without whose help the BLS training program could not been achieved. So, thank you everybody. Have a great year ahead. Long live Delhi ASI State Chapter. Long live ASI. Jai Hind. May I request Dr. Singhal sir?